Okay, so good afternoon to all our participants and all our faculty members, all support members, all medical practitioners, and all others who are joining us for the 2023 faculty, Family Medicine, faculty update course, 2023 update course. And today, we want to do the update course on current concepts in sports injuries, exercise, and rehabilitation. It's going to be a long section, so we're going to have a break. So we're going to start now at 2:30. We would have finished our first section. We'll have a 30 minutes break. We come back at 3 and do our second section. That will take us up to 5:30. Kindly bear with us as we go through this stretch. I'm sure you are going to be glad you joined us through. Before we start, I want to call on Dr. Ernest Opare, Enem Opare, to give us the opening prayer.
Heavenly Father, we thank you this afternoon for the opportunity as a faculty to have our memories and our knowledge refreshed through this update course. We thank you for all participants who have joined us. We pray for the speakers to be able to deliver excellent, and at the end of the day, we shall increase our knowledge in the name of Jesus.
Amen. So, we cannot start this program without having the chair of the faculty, that's the Ghana chapter of the Faculty of Family Medicine, giving us an intro to the update course and why we are doing this for this year. So, Prof. Chair, I can invite you to give us your info for this update course. Thank you.
Thank you very much, Dr. George Nketia, and your team for putting this up. You are all very much welcome to this year's update course. The update course is an annual event hosted by the college to, as it were, update trainers and residents on current events in some specialty areas. This year, we've chosen to do an update in sports exercise and rehabilitation medicine. SERM, it's about, one of the exciting subspecialties in family medicine. And we are very grateful for the assistance we are receiving from our external collaborators and also from our local trainer. They're a very intense group of, trainers, and that specialty, it's doing very well. So I'm very sure that this year's update will be exciting, and we'll update ourselves on events in this particular area. So for some residents, you might think that it's just to fulfill academic righteousness because it is, it's a demand. You are obliged to produce evidence of an update course, but I think we should just go beyond fulfillment of an academic obligation and really know that we need this update for our practice, for us who are trainers and other practitioners and other colleagues who might be on for purposes of knowing what's going on in this area. I think it's a good thing to do. So thank you very much. You're all welcome. Make sure you write enough notes. Of course, you're going to get the slides, but it's good also to put down some notes. Sometimes speakers might say some things which is not exactly on the slide, but might have a spur of inspiration and make certain important statements which you need to put down. So once again, Dr. Nketia and team, thank you very much. I think we have an array of highly experienced professionals in this area, both local and external. And I must once again say that I'm very, very, very grateful for all the support you're having in this specialty. So enjoy every bit of it. Make sure you don't sit down for too long. Occasionally get up, stretch, and make sure that you're having good circulation so that I can go through this whole program. Thank you very much, and God bless you all. Thank you. So back to you, George.
Thank you very much, Prof. Seth. I mean, thank you for this kind introduction. So to have, as I said, I mean, the members on the panel are very experienced personnel, I mean, in this field, I mean, both local and abroad. And we're going to have two sections, as I said. Our first section is going to be between now and 2:30. Our second section is going to be between 3 o'clock and 5:30, so that we can have some 30 minutes break to walk around. We are very much aware of sitting for long periods. And in fact, it's actually part of sports, exercise, and rehabilitation thing that we need to know. So we intentionally have that just to draw your attention to the fact that you don't need to sit too long. But our first presentation is going to be on pre-participation assessment in sports. One of the major challenges that we've had, especially now that we have in elite sports, is people really being assessed well before they get engaged in such sports. Sometimes when we are even recommending that our clients should do some form of exercises, a lot of times we'll be talking about moderate intensity, vigorous intensity, but I mean, do we assess them to know whether they can be involved in such activity? And to do this for us is no other but my very good friend. He's Dr. Benedict Okokwao. He's a specialist family physician and a global health practitioner. He's currently the National Leprosy Program Manager and serves on the leadership team of Global Partnership for Zero Leprosy. He's a fellow in training in sports, exercise, and rehabilitation, and his area of interest is in rehabilitation. I mean, he's married to one and only one wife and has 3 children. Help me invite my very good friend, Dr. Benedict Okokwao, as he takes position together the presentation of pre-participation assessment in sports. Kindly put your questions down. There's a Q&A section. You can put all your questions there. We'll be taking note of them. I mean, when all the 3 presenters have given their presentation, then we will come to the Q&A section where we will ask all your questions that you have got. Dr. Benedict Okokwao, kindly take the presentation.
Thank you, George, and thank you everyone for your participation in the CPD. My name is Dr. Kwao, and I'm a senior resident in sports, exercise, rehab medicine. Today, I'm going to speak on pre-participation assessment in sports. At the end of this session, I expect that we would all have an understanding of what pre-participation assessments, the importance of PPAs in ensuring safe participation in sports, understand the regulatory framework and evidence behind the conduct of PPAs, have an appreciable knowledge of the different components and considerations in carrying out a pre-participation assessment, and then all of us here should be able to support in the carrying out of PPAs in our setting. This is by way of the outline, and I want to go right into the presentation. By way of introduction, we all know that sports and exercise are important, and in recent times have assumed even greater importance. We have a relatively urbanized population. We are a low middle income country, and the risk of urbanization and sedentary lifestyle makes sports and exercise very important. We do know that physical activity has several proven benefits: prevention of non-communicable diseases like hypertension, like atherosclerosis, like diabetes, even some cancers. And we know that even in these chronic conditions, exercise, physical activity has a proven benefit. And exercise results in improvement in mental health, quality of life, and well-being. It's also the cornerstone of healthy aging. People who exercise are more likely to live longer and better without pain, without disabilities. However, like everything in this life, it is not without risk. Sports and exercise has some risk, despite the benefits outweighing the risk. And so to be able to support the performance of sports and exercise, we need to be able to optimize the benefits whilst making sure that persons participating in sport are safe. So this brings the idea of safe participation in sports and exercise. And the periodic pre-participation assessment is one of the ways by which we can ensure safe participation in sports and exercise. It is not the only one. Beyond that PPA, you need to regularly monitor your athlete, regular medical monitoring, and making sure that any decisions that are taken are based on the latest recommendations, vis-a-vis training program, nutrition, prevention of injuries, return to play. There are always up-to-date recommendations regarding these, and these should be applied in making decisions concerning athletes. Also, teams and schools are encouraged to have a written emergency medical action plan, which kicks into action when someone has suspected sudden cardiac arrest. And then the team members, both the sports and medical team members are taken through training on this medical action plan yearly, so that the team is always ready for that emergency. These sudden cardiac arrests are rare, but when they do occur, they can be quite devastating. Brings me to this story. I'm a footballer myself. You might know him. He's Mark Vivian Foy. He was then playing for Manchester City, and he was in the Cameroon national team. Somewhere in 2003, during the Confederations Cup, in the second half, in the 72nd minute, Mark Vivian Foy dropped to the ground away from all other players. And it was an apparent sudden cardiac arrest. He had a prolonged episode of CPR applied to him. He was sent to the hospital in an ambulance, but then sadly, he died shortly after arriving in hospital. The cause of death that was determined from the second autopsy was hypertrophic cardiomyopathy, which is inherited, which is usually silent, and can be associated with sudden cardiac arrest when there's extreme exhaustion, as he may have experienced whilst on the pitch. Following that, the World Body FIFA went into a number of tried a number of interventions until 2006 during the World Cup, when they introduced a standardized pre-competition medical assessment, which included an ECG and echocardiogram, understandably, because the move started from what happened with Mark Vivian Foy. We know that even with the Olympics, the Paralympics, the governing body has also come up with a statement mandating all participants to undergo PPAs regularly before they participate in sports. The International Olympic Committee has given a strong recommendation on pre-participation health examination, but has not made it mandatory and has left it for relevant sports authorities to decide. So there are some regulations behind carrying out the pre-participation assessments. Beyond the regulatory requirements, we know, and there's evidence that it is widely being practiced. In the US, most state high schools and colleges require students to participating in sports to undertake these PPAs before taking part in sports, and that's based on the recommendations by the various bodies overseeing sports in these institutions. And we know that in the US, almost about 30 million young adults, youth, are actually undertaking PPAs every year. In most European countries, PPA is mandatory only for competitive sports. In the rest, not mandatory, but strongly recommended. We also know that in most FIFA competitions since the 2006 World Cup, all players, increasing numbers of footballers have been subjected to a pre-participation assessment. However, there are controversies, there are concerns. Although the PPA is widely accepted, its use is currently not standardized. And there are important variations in terms of which categories of athletes to apply to. Do you apply to those who are just professional, or you extend it to apply to those engaged in leisure activities? Should it only be competitions that are licensed by the sport federations? There are also the issues about legal aspects. In Italy, for instance, it's compulsory. Anybody engaging in competitions has to undergo a PPA every year. It's not so in other countries. Also, the content of the PPA may differ. The cost of the PPA also may differ, and understandably from the different components that may be included in it. Now, there is limited evidence to support its effectiveness for detecting conditions that predispose athletes to injuries. Yes, you are able to optimize the performance of the athlete. You are able to ensure safe participation, but it does not. We need more evidence to show that it is effective at limiting injuries or illness. It needs a higher powered study, population study, to be able to come up with that evidence. Also, the other controversy is exercise is helpful. We know the benefits of exercise. Most PPEs or PPAs are not paid by insurance. They are paid out of pocket. So what happens to people who cannot afford? Now we are placing a barrier to undertaking sports. And what if in those communities, those athletes find themselves in, they do not have a service that can give them that assessment? And then there's the issue of resources. Yes, the pre-participation assessment is a preventive service, but it is not as holistic as the prescribed annual preventive screening services that primary care providers are supposed to provide. So what happens then? Sometimes in the US, for instance, some people might be tempted to use their insurance for the PPA, but it won't cover all the other aspects like the well child, the immunizations, the wellness examinations. And sometimes even if you try to put all together, it's going to extend the time in the service. So there are issues with carrying out PPAs, although it is generally accepted as being beneficial for the practicing sportsman. Now, much of the evidence I'm going to present here is based on statements or from two different bodies or two different sources. One is from the US, which is the 5th edition of the pre-participation physical evaluation monograph, which was developed by a combination of health bodies. You know, the American Academy of Family Physicians being part of that. And I will just highlight that because I'm a family physician myself. And then from Europe, you have the European Federation of Sports Medicine Associations. The Scientific and Educational Commission came out with a consensus statement on pre-participation assessment. So, what is the pre-participation assessment? You would realize that sometimes I refer to PPE, sometimes I say PCMA. It's the same thing, either pre-participation evaluation, a sports physical, a pre-competition medical assessment for FIFA, or a periodic health evaluation. And whatever it is called, it is performed in the primary interest of the athlete or the sportsman, and usually under the responsibility of a sports medicine physician. But it can also be carried out by trained primary care providers. And it requires the free and informed consent of the athlete, and if applicable, the guardian. Now, if the PPA identifies a serious medical risk, the physician must strongly discourage athlete from participation. However, based on advice, it is ultimately the athlete's decision. What is the goal of the PPA? The goal of the PPA is primarily to maximize the health of athletes and their safe participation in sports. And how does it do that? Through early detection and prevention of potential severe or life-threatening complications during both leisure and competitive sports, determining and improving the level of performance of athletes, helping the coaching staff to be able to select and optimize training according to the determined health status, counseling the athletes regarding health issues, and very importantly, it helps establish a relationship between a SEM physician and the athlete, even before an injury has occurred. There are other goals. It is a medical and legal document once you have completed the process and signed off. It allows the collection of baseline data on medical history, allergies, vital signs, neurophysiological testing, body composition, and other components that can be referred to if the need arises, and may also provide to the young practicing sportsman an exposure to the health system for preventive health care, so that that young individual can have education on issues such as smoking, sexually transmitted diseases, and supplement use. I call this a triple S. It's also an opportunity to review medications. The athlete may be on some supplement which may need some exemption based on the doping rules. And this is the point at which you can pick it up if you carry out the pre-participation evaluation. When do we carry out PPAs? The PPE 5 recommends different evaluation frequencies based on age group. For a high school and younger athletes, it is asking for a comprehensive PPA every 2 to 3 years with an annual focused history update in between. And for college athletes, it is asking for a single comprehensive evaluation during the first year, followed by annual history updates. It may also be carried out in relation to competition, as we have with the PCMAs for the FIFA competitions, and as based on the IPC's recommendation for Special Olympics. It is best done off-season, however, or approximately 6 weeks before the competition. This allows for further evaluation and treatment or rehabilitation if a problem is identified. Now, it can also be incorporated into regular preventive healthcare visits with an athlete's primary physician. And it has an advantage because there the patient's history is already there. The athlete has probably has a rapport with the primary care provider already. But as I mentioned earlier, it has challenges with regards to reimbursement, time spent in the encounter. Now let's look at the different formats for performing PPAs. You may have what we call the assembly line or locker room PPA, usually used when you are doing mass screening for a whole group. One medical officer, usually in a room, maybe in the practice, but usually in the school locker room or cafeteria, and that medical officer is reviewing all the athletes, probably lined up to see him or her. But the problem with this is that it allows little time to thoroughly review the athlete's medical histories. It offers little privacy, if any, for physical exam or private exam. And it is one of those that if you can, you should avoid doing as much as possible. Then there is a station-based exam. Here too, it is being used for a large group of people at a time. But the advantage or the modification from the assembly line is that you have different stations where the athletes are made to pass through. So you may have a vital station, you have a history station, you have a physical exam station, and so it makes the work less laborious on the one that is carrying out the PPA, but it requires multiple volunteers. And there is loss of continuity because you're seeing different people, and it's not always that your medical history gets stored. But it is the most appropriate if you have a large group of athletes to evaluate as part of their PPA. Then there's the office-based exam, which should ideally be conducted in a patient's medical home where he or she is already an established patient with a well-known medical history, and doing this in that office setting allows for privacy and examination, discussion of specific issues. The only challenge here is that usually it's a primary care provider that is doing it and may not always be familiar with the specific sports exam protocols that athlete may require. It is the most ideal, but let's note that doing this in an urgent care or retail clinic is discouraged. What are the components of the PPA? There are 3 diagnostic components, which may not all apply depending on the type of exercise, depending on the type of competition, depending on the regulatory framework. So you have the health status, which is always included. That's basically your history, your physical exam, any other investigations that may be needed. And then there's the next one, which has to do with anthropometry and performance or mobility test, which assesses body posture, body development, compares to the somatic biotype, and also looks at performance. Then there's a final bit which could be included, which is a functional and exercise capacity. And it tries to it's tailored towards the predominant type of effort required for that sport discipline. Usually for any elite athlete, you want to have included a functional and exercise capacity to make your PPA complete. So the first component is the health status, and it is based on family medical history, personal medical history, the training history, the training information, and then also medical complaints. And we started on 12. Time we start. Okay. So after doing that assessment subjectively, you do an objective physical examination. You want to look at the skin, the lymph nodes, the musculoskeletal system, the respiratory system, cardiovascular system, but also the abdominal, neurological, ophthalmological, or ENT examination. And you may include an ECG with digital recording and software, and in some cases, blood and biochemical tests. But these are infrequent. They are not always recommended. Even in the US, the American Heart Association does not recommend adding an ECG routinely to asymptomatic athletes undergoing a PPA. The history has been shown to be the most important component of the PPA, and that one alone covers about 88% of medical conditions and 67% of the musculoskeletal problems. And it should include questions assessing the risk of the presence of silent, severe hereditary or cardiovascular disease, which can predispose to sudden cardiac death. Beyond the basics, some other areas of concern should be explored, such as the risk of concussion in sports like rugby, football, and American football, and then disordered eating, and then red S. Red S is relative energy deficiency in sport, where the energy the athlete is expending far outweighs what the athlete is taking in through their intake. And then there is also the exercise-induced asthma. So these are specific to sports, and the history should attempt to explore these further to identify if there are any areas that need to be addressed. Now, once there's a positive screening question, this then prompts a more detailed targeted history and examination in that area of concern. Concerning sudden cardiac death, in a history, you have the family history. And with the family history, you're looking for any history of premature death before the age of 50, sudden, unexpected due to heart disease, or any history of cardiomyopathy, coronary artery disease, Marfan syndrome, or arrhythmias, or any other disabling cardiovascular disease. And then in the patient, you try to rule out history of syncope or near syncope, exertional chain, chest pain, or discomfort, shortness of breath, or fatigue out of proportion with a degree of physical effort, and palpitations or irregular heartbeat, all in an attempt to try and find out if there may be a silent underlying cardiac disease that may produce unwanted complications when the athlete is under extreme exertion. Then with examination, you want to perform the examination in a very controlled environment with someone who is experienced in general medical, cardiovascular, and musculoskeletal examination. It allows the opportunity to expand on issues that may have been picked up in the history. Remember, we said that the history would uncover about 88% of medical conditions and 67% of musculoskeletal problems. So here you're able to zoom in on the areas that have been highlighted by the history. You may find new problems as well. And the focus is really on the cardiovascular, the pulmonary, the musculoskeletal, neurological, ophthalmological, and otolaryngology screening. The CBS exam should, at the minimum, include auscultation in supine and standing positions with both the diaphragm and bell of stethoscope. If you want to augment the intensity of your murmurs, you can listen when the patient is squatting, because with the increased venous return and the increased pressure in the arterial system, the murmurs become louder. Now, a thorough neurological exam may be necessary if the patient has a history of concussion, a seizure disorder, or cervical spine stenosis or spinal cord injury. What do we do regarding musculoskeletal screening? It is focused mainly on finding evidence of previous injuries and current symptoms. And you get that both from the history and physical examination. Remember, I mentioned that the history uncovers, the examination helps you zoom in and be able to better define what the problem is. And a clinician can detect up to 90% of significant MSK injuries. And the physical exam alone may be low in sensitivity, but very high in specificity. And some of the signs and symptoms of injury can be pain or tenderness, asymmetric muscle bulk, strength or range of motion, or an obvious deformity. And once a problem is identified, you then have the site-specific examination. You will not carry out all the special tests of the knee joint in a routine exam unless there is evidence of a problem in the knee. Then you go in to carry out all your tests as well. Now, there's a quick 2-minute exam that you can perform, quickly looking at everything. The athlete faces the examiner. You're looking at the AC joints. You're looking at the general habitus. The athlete looks up at the ceiling, the floor, over the shoulders, and then touches the ears to the shoulders. You are looking at the cervical spine motion, shrugs the shoulders against resistance, the trapezius strength, abducts the shoulders 90 degrees, holds against resistance. That's a deltoid strength. Rotates arms fully, shoulder motion, flexes, extends the elbow. You're looking at the elbow motion, arm at the sides, elbow 90 degrees flex, and then you pronate and supinate the wrist, elbow and wrist motion. So all these steps test different joints, different parts of the MSK system. And once there's a flag, you go in there to do a more detailed examination. This is a sample pre-participation evaluation form. You'll see the top part of it has the demographic information in case of emergency, who to contact. Then the form is designed such that you can complete the form. Okay. Some of the questions I mentioned, I understand I have 5 minutes to go. So then with the physical, you also see you can quickly indicate if it is normal and the abnormal findings, and then at the end, note whether the athlete has been cleared or not. Is ECG important? There is evidence that ECG is important. It is very sensitive in hypertrophic cardiomyopathy, right ventricular cardiomyopathy. It can identify your coordination problems, your arrhythmias. And what we know is that the digital ECG recordings based on the current international criteria are highly sensitive and highly specific. As I said earlier, the American Heart Association does not recommend ECG in asymptomatic patients, but does not go against it if some local program wants to do that. You may do a screening ECG and echocardiography as well. Now, athletes have physiological changes that show up on the ECG, and that is why it is not routinely recommended, because there may be a lot of false positives when it is read. Right? This table attempts to show you the physiological changes and some of the abnormal changes that would suggest severe disease. This is the QRS complex, the normal QRS complex. Morbid's type 1 second degree AV block, where you have the PR interval getting longer until there's a mixed beat. The type 2 AV block, and then the third degree AV block are all contraindications to sport. The Brugada syndrome, where you have a high takeoff and then the sloping elevated ST segment into a T inversion, is also a contraindication. Any of the supraventricular arrhythmias, AF, atrial flutter, SVT, as well as having more than 2 PVCs, premature ventricular contractions, in 10 seconds. This is how you would use the ECG. You do your history, physical exam, ECG at rest, and if there are abnormal findings, then carry out a more detailed stepwise examination, possibly then introduce other tests like the stress test and the echocardiography or Holter. And then if there are still issues, bring in the cardiac MRI as a very sensitive screening test. Anybody who is above 6, any male above 6 inches, and any woman above 5 inches 10, who has any of these, the stigmata of Marfan's, the history of Marfan syndrome in the family, myopia, ectopic lens, that individual will require an echocardiogram and a slit lamp examination. It's also important to screen for mental health. This is a recognized major issue in young adults. You also need to look out for bullying, sexual abuse, sleep disorders, substance abuse, which can affect the mental health of patients. The commonly used scales we use are the PHQ-9 for depression and the GAD-7 scale for anxiety. You have them here you have the PHQ-9 here. When you're using for screening, you need a score of 10, and it has over 80% sensitivity and specificity. When you use the general anxiety disorder 7 scale, that one to a score of 10 has over 80% sensitivity and specificity for general anxiety disorder. But can also pick up social anxiety disorder, panic disorder, and post-traumatic stress disorder. Lab tests are not routinely recommended for asymptomatic athletes. However, note that some biomarkers like vitamin D and ferritin can directly impact athletic performance. Also, checking for cortisol and creatinine kinase can give insights into whether there's overtraining or an injury prevention. So when you are looking at performance training, these may be brought in to supplement the PPA. Athletes with disabilities are taken through the same kind of process as any other athlete, just that we know that they are more likely to have certain peculiar issues. Cerebral palsy may have, people with cerebral palsy may have decreased flexibility and spasticity, for instance. Spinal cord injury and wheelchair athletes, you know that they may have autonomic dysreflexia, where you have an exaggerated sympathetic response in response to noxious stimuli. They may also have pressure ulcers because they are sitting all the time. So these are specificities that you need to look out for when you're dealing with athletes with disability. I mentioned the other component, which is anthropometry. Now, anthropometry, to summarize, is looking at how the body shape is, how the body measures, and whether it fits the sports. And certain sports have a peculiar somatic biotype that would enhance performance. In the same way, you carry out performance and mobility tests. And the idea is to try and find out the patient's baseline, for performance, so that you can be able to include this in your strength and conditioning programs. Some of the tests for mobility quality are the deep squat, the hurdle step, and the in lunge. And as the athlete carries out these tests, you're observing to find out if there are issues with any of the steps. The functional and exercise capacity is one that is usually done for elite athletes, and it includes a neuromuscular evaluation, includes a psychological examination, and a cardiopulmonary exercise test, which is a gold standard to monitor your responses to exercise capacity, determining your oxygen metabolic demand, determining your cardiorespiratory fitness. And usually we say that for an elite pro athlete, if you do not perform the cardiopulmonary exercise test, your PPA is incomplete. What are the outcomes of the PPA? There are three. The athlete may be medically eligible for sports performance without restriction, may be eligible with recommendation for further evaluation, or may be not medically eligible, either with restriction or rarely disqualified completely from participation. In case of a restriction, remember shared decision-making involving the patient, their family, and their team. In some cases, you may need to consider an alternate activity, and the guidance is based on the type of activities. This table tries to classify the sports by virtue of the intensity, either static or dynamic. So if a patient, let me give an example, if a patient has a bleeding disorder, that patient is not supposed to take part in high intensity contact sports. So you don't expect such a patient such an athlete to be given the clearance to take part in boxing, for instance. This list lists the contraindications participation in sports, the absolute contraindications. I found it interesting here that sickle cell disease is one, but the truth is that with sickle cell disease, they are functionally limited to low intensity activities. Uncontrolled asthma, active tuberculosis, some of the ECG findings we showed earlier, uncontrolled seizure disorder, uncontrolled hypertension, they are all contraindications to participation in sports. Ending now, sports and exercise medicine plays an increasingly important role in supporting athletic performance and ensuring safe participation. And preventive practices such as the pre-participation assessment helps us identify those risk factors very early to take the actions in time to prevent an unwanted occurrence. And it allows the athletes to perform sports and exercises to get the maximum benefit. We know that the methods have not been standardized. There's a need for that. But even in our system, even in our own small way, we can continue to support the carrying out of PPA for persons undertaking sports in our society or in our country. It is an important entry point into the health system. And as family physicians, we see this as an opportunity for preventive medicine to counsel the athletes and to make sure that all other preventive services have been taken care of. Thank you very much for your attention. These are my references. I'm sure that the slides will be shared in due course. Thank you.
Thank you very much, Dr. Benedict Okopa, for this presentation. You took 3. Sorry, thank you very much. I think I was muted. I said that we appreciate Dr. Benedict Okopa for his presentation. It's taking 3 minutes of my time, but I said for today, you'll be pardoned. Next on the list, we have nutrition in sports. And I said that if you have any questions, kindly put it in the chat box. We have a number of questions. We'll be putting it together so that in due time, we will ask our panelists the questions. So to take the next one for us, we have my own good friend, Dr. Frank Eko Ata-Hayford. He's a senior lecturer, a researcher, and a dietitian with the Department of Nutrition and Dietetics, University of Ghana. He's currently the undergraduate program coordinator for dietetics and a member of the College of Health Science Academic Board. His interest areas are in clinical, public health, nutrition, epidemiology, and nutrition in sports. In fact, he's authored several peer-reviewed publications and presented in several conferences with interest areas in research-based nutrition, sports, and health. He's currently a visiting scholar researcher of the University of Sheffield, UK, Leeds University, UK, Queen's University, Canada, and University of Ghana, University of Cape Town. He's also married to one and only one wife, and currently also has 3 children. I hope you'll be following some people's footsteps. Dr. Frank Eko Ata-Hayford, kindly upload your slides and take about.
Yeah, so thank you very much, Dr. Nketia. I hope everybody can see me and also can hear me loud and clear.
Yeah, we can see you and hear you loud and clear.
Okay, and also my slides. So thank you very much, Dr. Nketia and the organizers of this year's update course. And I would also want to thank you for inviting me an opportunity to share with you all. So when I was invited and I was asked to look at sports nutrition, I mean, I just told myself, oh, blimey, I mean, it's such a huge area, and I would need probably the whole about 3 months to cover all the relevance or aspects of sports nutrition. But then what I attempted to do, or what I'm going to attempt to do this afternoon, is to tailor the presentation to sort of be in line with what generally is being considered. So I decided to sort of tailor my presentation to look at the role of nutrition in sports injury prevention, recovery, and rehabilitation. So by way of the outline, we'll briefly look at the importance of nutrition in sports, and then also look at the goals of sports nutrition
and also the general evidence that is actually supporting the importance of nutrition in injury prevention, recovery, and rehabilitation. And we would look at this, looking at how nutrition is applied before, during, and after injury, especially when it comes to the role of nutrition in injury prevention. And we would also quickly look at the role of nutrition in injury recovery and rehabilitation. And then if there's time, quickly look at hydration in sports, since we know it's very, very important. When we talk about nutrition in sports, I mean, it's well documented that good nutrition enhances athletic performance. Besides the our traditional importance of nutrition, which is primarily for energy, for building of or repairing of worn out tissues and cells, and also for protection. Research have shown that nutrition really, besides this important function, have been shown to enhance athletic performance. And how does it enhance athletic performance? The role of nutrient in providing fuel for exercise competition, promoting muscle growth, repairs, and rejuvenation is, as I said, has been widely acknowledged. And for an athlete, nutrition is very crucial because what it does is that it supplies the energy they need before, during, and after every competition. According to the British Nutrition Foundation, enhancing performance in sporting activity, maximizing the likelihood minimizing the likelihood of illness and injury, and also ensuring the best possible recovery following an activity are some of the benefits of proper nutrition. And in line with that, this have actually given rise to a lot of scientific nutrition strategies being actually adapted in modern day nutrition. And I would say to a large extent, I remember some years back, we had when the Blaster had they took part in the AFCON, I think in Cameroon. I remember when they came back, one of the things I actually heard the minister talk about, I think then we were being coached by the Israeli Avram Grant. And one of the things that really came out clear from that tournament, even though we didn't win the cup, that they really paid attention to their nutrition. And he was quite impressed that the coach really was very much concerned about what they eat. So when we talk about these scientific strategies, what are they? They are approaches that have actually been adopted to boosting performance using evidence-based nutrition scheme. And these strategies currently are emerging as very helpful, especially in improving athletic performance, of course, in promoting muscle regeneration and also growth. And what are some of these strategies that currently are being adopted? They include, the concept of carbohydrate loading, the concept of nutrient periodization, of course, carbohydrate loading, a situation where, prior to a competition or a tournament, athletes sort of build up carbohydrate in a certain pattern in order to give them, enough energy, during the competition. And of course, some have also resulted in taking dietary supplements such as beta-alanine and vitamin D. And all these things are some of the strategies that are being adopted. And as I said, such approaches have been shown by study to be very helpful. Okay. So a study that was conducted by Hans in 2014 and Martin and colleague actually showed that non-athlete marathon runners, right? And of course, this research was actually done among non-elite marathon runners and also novice cyclists. And what they saw was that proper nutrition actually helped them to decrease the time it took to complete, the marathon. And of course, when you talk about cyclists, usually they have these trial times. And the trial times, you sort of have the opportunity to ride, over a certain distance. And then, of course, you are timed to see how fast you are. What they realized among these two cohort of athletes was that for the marathon runners, the time it took to complete the marathon, and for the cyclists, the time it took, to complete that trial time were all decreased. So when we talk about these nutritional strategies, what are some of the effects that have been shown generally when it comes to poor nutrition? So those are when athletes or when elite athletes do not put in proper strategies in terms of nutritional strategies to improve their performance. What are some of the effects that have actually been found over the years? They've realized that poor nutrition strategies, or when athletes do not even put in any strategies by way of nutrition, it's been shown to decrease their strength. It's been also shown to decrease their power, endurance, immunity. It also leads to chronic fatigue. And we know in sports, being able to, to have good stamina, without easily becoming fatigued, plays a very, very important role. It's also been shown to cause soreness, especially when athletes are in competition. You have competition like the World Cup that actually spans over a month. Poor nutrition have been shown to lead to soreness and joint pain, of course, macronutrient deficiencies. And these macronutrient deficits really have been shown to result in quite a lot of things. So when it comes to sports nutrition or nutrition in sports, what are the overall goals, or what are the main goals? So the main goals in nutrition in sports is to provide the necessary energy before, during, and after a competition. Again, to also help to regulate the body's metabolism, of course, whilst an athlete is preparing to compete, or whilst competing and after competing. There are quite a lot of changes that happens physiologically and metabolically. Also, more importantly, and that is what we are actually going to focus on, is to provide nutrients to maintain and also to repair tissue. As my colleague, the first presenter actually said, and he was right. I mean, sports, you can never be involved in sports, without sustaining an injury. And no matter how well you eat, or the nutrition strategy, but then the thing is, how do you eat to be able to actually reduce the risk of this injury, or to reduce the frequent occurrence of this injury, right? Or again, how do you eat to be able to sort of recover very early? Of course, we all know that modern day sports and athletics is quite competitive. We all have a very good idea. Those of you who are sports football fanatics, you know how large teams are now, and that when as an athlete you go, you are injured, right? And you are benched whilst you are recovering. Of course, you have 2 or 3 people waiting to take your place, and if you're not lucky, by the time you come back from injuries, or by the time you recover, if you don't recover early enough, somebody will take your place, and that means that you would warm the bench. Of course, all these are some of the reasons why people have gone their way to actually exploit the possible effects of nutrition in either delaying, preventing, or reducing the risk of some of these injuries that are associated with sports, or even when they are injured. They explore ways, by way of nutrition, to actually assist them come out of injury and back to competition. So let's look at what some of the nutrition strategies and the evidence are saying. So research in these kinds of adopting appropriate nutrition strategies, right, in the area of injury prevention and recovery, have shown a lot of promise, and we'll very soon look at some of the evidence. And these nutrition strategies, especially when it comes to injury prevention, are aimed at, how the are aimed at the athlete's pre-game meal. Okay, that is the a meal that are taken before a competition, meals that are taken during the competition, and then meals or foods that are taken post competition, and all these things. So the nutrition strategy that have been adopted in the prevention, and then the prevention, the recovery and rehabilitation, usually have been actually aimed at targeting these aspects of the athletes' sort of game. Okay, looking at the pre-game meals, looking at the meals they take during the competition, and of course after the competition, the meals that they eat. So let's look at some of the evidence. What are some of the evidence saying concerning the role of nutrition when it comes to prevention, recovery, and rehabilitation? So for the sake of time, we'll look at a few of them. So Pompetis in 2016 actually looked at the effects of carbohydrate intake on maximal power output and cognitive performance among 18 high-level athletes who are involved in explosive sports. And it was a randomized, double-blinded study. And what was the outcome, or what was the result? They actually noticed that, or the researchers actually noticed that consuming 250 mils of carbohydrates 30 and 60 minutes before exercise increased peak power production. It also reduced muscle fatigue, right? And it also sped up information processes, especially when it comes to visual detection, without affecting accuracy. So that is one evidence that actually points the role of nutrition, how important nutrition is. Then another study, a systematic review that was also conducted among college athletes, where they looked at the effects of polyphenols, right, in exercise performance. And this was actually done by Malagita and colleagues in 2013. So they looked at the polyphenols. They did a systematic review to look at polyphenols in exercise performance, and also the prevention of exercise-induced muscle damage. What they found out was that homeostasis of cartilage tissue after injury increased skeletal muscle. Then again, another randomized control trial that was done in 2016 among 40 males. So we're talking about 20 boxers and 20 cyclists. It was a randomized control trial. There, what they did was that they supplemented for 4 weeks. They gave supplementation of isolated protein, so in a form of a shake. And what they noticed was that protein consumption led to reduced rise in muscle damage. It also reduced inflammation and oxidative stress indicators. And what it also did was that it also led to a reduced decline in muscular performance after strenuous. It reduced the decline in muscular performance, after the athlete had engaged in strenuous activity. So these are some of the evidence that is actually pointing to the fact that nutrition plays a very, very important role when it comes to prevention, injuries, recovering from injuries, or when athletes are going through rehabilitation. So now let's specifically look at the role, these nutritional strategies that have been adapted over the years in the injury prevention. Okay. So for the pregame, what are some of the nutrition strategies that have been adapted before an athlete, gets into a competition, or they start a competition competition. And what research by Benin found was that usually this ranges from 5 minutes to 6 hours before a game, with meal size reducing as closeness to the game as possible. Okay? So they realized that this effect, works, ranging from 5 minutes to 6 hours before a game. So the closer the time to the competition, the meal size also reduces. Of course, it's not advisable that a few minutes before a competition, you eat very heavy. And this actually reminds me of something that I heard, and I don't know if any of us here, also heard. Well, it was about. I wasn't also sure whether it was true or it was just a joke. It was about one of our very famous boxers, who apparently a few hours before his boxing bout in the States, it was alleged that he really wanted to eat his favorite Ghanaian dish. So he was craving for it. So he ordered that that food is provided. Well, apparently after the boxing bout he lost, unfortunately, and he complained that during the fight he was sort of felt the food moving in his belly. I don't know how true it was, but the closeness of the meal size to the closeness of the closeness of the amount of food that you eat, to the start of the competition plays a very, very important role. It's also been shown that pre-game meals have been shown to decrease the risk of damage to the muscles with readily available carbohydrate and amino acid. This has been shown to reduce exercise-induced muscle catabolism. Then again, one of the strategies that have actually been adopted is making sure that the athletes do not have deficiencies in certain micronutrients. So, for instance, it was realized that preventing deficiencies in nutrients associated with bone health is very crucial when it comes to prevention of bone injuries. So, for instance, what they found out was that vitamin D and calcium deficiencies have also been associated with increased risk of stress fracture. We know that all these are injuries, especially when it comes to contact sports, like football and others. So preventing nutritional deficiencies, so screening to make sure that the athlete is not deficient, in these micronutrients, or ensuring that the athlete is sufficient in these micronutrients have actually been shown to decrease the risk of stress fracture. Again, it's been shown that having enough energy before a competition really helps. So low energy availability have been shown to significantly increase risk of stress fracture, particularly in female athletes. Hence, a lot of athletes, have adopted this concept of carbohydrate loading in sports. And when we talk about carbohydrate loading, as I mentioned earlier, it's a practice that is used by athletes to saturate their endogenous stores of muscle glycogen before a long duration event. That typically leads to depletion of glycogen. And this really have been well perfected by a lot of athletes who have actually come out to say that yes, it really has helped them in terms of their stamina. One other nutrient that has also been of interest, especially in the prevention of injuries, is omega-3 polyunsaturated fatty acid, because of its anti-inflammatory properties. But omega-3 fatty acid have been shown to help prevent muscle damage, after eccentric exercises by reducing post-exercise inflammatory response. So, and of course, when we talk about omega-3 fatty acid, rich sources include our sardines, our salmon, our tuna, and our mackerel. It's also been, shown that supplementation with vitamin D, C, and E, as well as creatinine and some polyphenols, are used in preventing skeletal muscle injuries. So once these are supplemented, or once these adequacy of these are ensured, before a competition, it's been shown to actually prevent a possible skeletal muscle injury. However, there is limited evidence existing to support. However, there is actually limited evidence that exists to support in the absence of a deficiency as to whether, in fact, when it comes to micronutrients, it's actually one of the areas that there have been quite a lot of debates about whether these supplementations, even though it is good to ensure adequate intake, and their adequacy have been actually linked to prevention of injuries, its effects, in the absence of deficiency, as to whether they really have, their effect is felt, beyond deficiency, whether it works. That has also actually been a bone of contention. So people believe that once the athlete, is able to meet, this requirement, via their normal diet, and then they are not deficient, these nutrients do not confer any extra benefits, beyond what they do if you are able to meet them in your normal diet. Again, it's also been shown that hydrolyzed collagen consumption, especially 10 to 15 grams per day, usually when you take them 30 to 60 minutes before exercise, is helpful in collagen production, and also it is helpful in preventing joint, tendon, and ligament injuries, especially when it comes to combative sports. Okay? And when we talk about this collagen, they are basically made from bones, tendons, and skin of cattle, the chicken, or fish. Okay? So these are some of the nutritional strategies that have been adopted over the year to help in pre-game nutrition to that is before the competition, strategies that have actually been shown to help to reduce the risk of injury. So this figure is actually showing what your typical athlete meal, plate would look like for depending on the exercise regime that the athlete is undertaking, before competition. And if you look at it, you would see that the plates, in terms of the composition of the various meals, that's whole grain, lean protein, vegetables, or fruit, changes according to the kind of exercises. Of course, this is not a one-size-fits-all, but this is a guide actually to help. And these are some of the guides that are actually used or modified, okay, to help to be able to meet those specific nutritional needs that is able to help in the prevention of injuries. I must also say that, of course, this also applies during, this also applies when it comes to, coming up with foods or meal, right, to help athletes prevent injuries during the competition or even after the competition, right? What you need to do here is, just to modify and vary, based on the outcome that you want. So, for instance, if you are giving these meals to an athlete to help to prevent the injuries, there are specific ones that you would, based on research, you would ensure that it is more present or it is more available compared to the others. Of course, when it also comes to injury recovery, there are specific nutrients that would look at, right? Next, that inclusion of those particular foods would actually help with recovery and rehabilitation. So now let's look at nutrition during competition. What the evidence says. So nutrition during competition will also be helpful in preventing injuries. And one of the main strategy, right, when it comes to nutrition, providing nutrition to prevent injuries during the competition itself, is trying to reserve endogenous glycogen stores, okay, by consuming, enough of the nutrients. Okay. So, for example, in 2014, Rollo et al. Noticed that the consumption of 60 grams of carbohydrate during a competition was shown to delay fatigue and also enhance performance. And how did this happen? Of course, it helps to reserve, endogenous glycogen stores, okay, so that whilst the athlete is going through the competition, they do not deplete their glycogen stores very fast, leading to fatigue. Also, we all know that when it comes to muscles, when muscles become fatigued, the risk of injury also increases. Okay? So it is also one of the concepts in eating well during the competition, so that you do not, an athlete do not easily become injured, right? So the nutritional intervention that is put in place is to help what? Is to prevent the muscles becoming easily fatigued. So let's look at some of the recommendations. So carbohydrate during endurance exercise that is more than 1 hour, right? It's actually shown. So if you give enough carbohydrates or adequate carbohydrates, and of course, when we talk about giving enough or adequate carbohydrates, it's based on so many things. It's based on the kind of event that athlete is participating in. So when you take a footballer or you take somebody who is throwing the puck or somebody who throws the javelin, their carbohydrate intake will vary. Okay, it's the same way when you take somebody who is, lifting the weight. So these are all based on assessment and needs. But what the research has shown is that if adequate carbohydrate intake is given during the competition, that is greater than 1 hour, it's been what the carbohydrate does is that it's been shown to spare muscle glycogen, ensuring sufficient energy amount during the latter stages of exercise. And this is also very, very important. Of course, that is also one of the things that personally I observed with a lot of our junior national team players some time ago, that mostly they are very talented, they are very, very good, but for some reason, they play their heart out up to 70 minutes, and then after 70 minutes, we realize that they are, the stamina is going down, they easily become fatigued. And one of the strategies that can be used to overcome such phenomenon, of course, you compare them to elite athletes who are playing professional football. They can run for 90 minutes. Okay? It is to be able to get enough energy or protein, carbohydrates during the competition. Of course, this is also the reason why we realize that in modern game, whether athletics, whether football, we realize that from time to time the players, go to the touch line and grab something and then either drink or eat, and then they go back. So that is making sure that whilst the competition is going on, the athletes actually get enough of the carbohydrates to spare muscle glycogen. It's also been shown to maintain blood glucose concentration, preventing low blood glucose. And it's also been shown to delay fatigue. So when we talk about glucose ingestion, it's been shown to spare indigenous protein also, which is very, very important. Of course, we know the functions of protein. So if during the competition, the athlete is, is well fed or is provided the adequate amount of carbohydrates, what it does is that it actually spares endogenous protein. Okay, and what it also does is that it spares endogenous protein, and the carbohydrate is fed in fed cyclists, right, without glycogen depletion. So this is also another work or evidence that is showing that injection of glucose help to do that. For competitions, that goes beyond 1 to 2 hours, right? For competitions that prolongs beyond that, it's been shown that 30 to 60 grams of carbohydrate each hour, right, helps. And also when the competition is beyond 2.5 hours, 90 grams of carbohydrate consumption have also been shown to help. So those are some of the, yes.
Please, you have 5 minutes to go.
I have 5 minutes to go.
Yes.
So let's look at the post-game nutrition strategies. So of course, we've seen the importance of nutrition before, during, and then what about some of the strategies that have been adopted for post-game nutrition, that is after the competition. So these nutrition strategies for post-game recovery are particularly important, right? Especially when it comes to repeated high-level performance, okay? Especially when multiple competitions are held in succession. Of course, it is also very important when you are in tournaments. And we know that in tournaments, once you are in and then the tournament progresses, you need to stay fit. So if you are not knocked out, or if a team is not knocked out earlier on in the competition, it means that the team would make sure that they recover on time, especially when you are playing in competitions where almost every 48 hours you have to go and compete. Okay. In that situation, adequate post-game recovery is aimed at replenishing glycogen stores, facilitating optimum nutritional protein synthesis, and also preventing injuries. Because of course, when you are in a competition and your best players are all injured during the competition, it actually affects the outcome in terms of, so injection of both carbohydrate and protein as feeding strategy for athletes during recovery have been shown to enhance performance. So for instance, a research that was done in 2017 by Rankodas actually showed that intake of 1.2 grams of carbohydrates per kilogram body weight per hour and 40 grams of protein within 20 minutes after the game as a recovery strategy aided in restoring glycogen stores and also facilitating glycogen synthesis. Okay. Then apart from the protein and carbohydrates, it's also been shown that using antioxidants and anti-inflammatory nutrients alongside the protein and carbohydrate intake may also be useful in promoting recovery. Okay. Yeah, it may also be very, very useful in promoting recovery. However, when it comes to recovery or prevention of injury, alcohol intake have been shown not to be very good, because what it's been shown to do is to impair recovery, okay, and adaptation to training. What it does is that it leads to stifling of the skeletal muscle response to anabolic signals. Okay. So these are some of the nutritional strategies that are available in the prevention of injuries. What about when it comes to recovery and rehabilitation? Because as I said from the beginning, as a sports, as an elite athlete, you cannot actually go without injuries. I mean, it's likely that at a point in your career, you get one injury or the other. So what are some of the strategies that have been shown to work, especially when it comes to injury recovery? And as I mentioned from the beginning, once you are injured and you're on the treatment table, somebody else is playing your position. So nutrition in injury recovery and rehabilitation is aimed at facilitating healing and return to competition. Okay. And when it comes to healing of exercise or competition-induced injuries, it occurs in two stages: healing and recovery, rehabilitation and return. Okay. Both phases have been shown to rely on nutrition. So when it comes to the first stage of recovery, it is characterized by inflammation and healing, right, and loss of muscle mass. Okay. Nutrition strategies are therefore aimed at attenuating inflammation and also repairing muscle damage and also preventing significant loss of muscle tissue. So when it comes to nutrition strategy, in handling the first part or the first stage in recovery, this is what it is aimed at. The second stage usually involve reorientation to training, right, and competition. Okay, and this have been shown to be associated with muscle protein synthesis. Hence, when it comes to the nutrition strategy to actually help with this second stage, it is usually, tailored towards helping the athletes to synthesize protein more, okay, because it is very, very important when it comes to the recovery process. So let's quickly and briefly look at the caloric needs when it comes to this aspect, when it comes to this aspect, that is injury recovery and rehabilitation. So caloric intake is very crucial, right? As inadequate calories have been shown to affect muscle protein synthesis, right? Energy requirement for injured athlete increases in proportion to the severity of the injury. Okay? So as I said from the beginning, it differs from the kind of competition that you are in or the kind of sports that you are involved in, and of course it also depends on the kind of injury. So increasing caloric intake by 10 to 15% of estimated energy requirements have been shown to be beneficial when it comes to injury. Okay. Of course, when it comes to recovery and rehabilitation, one of the very key, because muscle synthesis is involved in the recovery, amino acids have actually been shown to help. So increased need for amino acids following an injury without adequate protein, the body then meets its demand by breaking down the skeletal muscle, and this is what you wouldn't want to do. So ensuring that the individual have enough protein during the recovery phase is very, very important, because this is what you wouldn't want to happen, that the individual is not able to meet their protein need, and hence the body then would rely on breaking down the skeletal muscles to provide that amino acid to help in the recovery. So when we come to protein intake, nutrition support should be able to provide at least 1.6 to 2.5 gram per kilogram body weight of easily digestible, high biological value protein, okay, usually high in leucine content. When we talk about food sources that have this, we are talking about chicken, beef, egg, milk, and then fish. However, for those athletes who are unable to meet this recommendation via the diet, okay, protein supplementation, such as the use of whey protein, is also encouraged, because whey protein formulas are quite high in amino acids, especially leucine. Then one other, when it comes to fat, so that is for protein. When it comes to fat, omega-3 fatty acid, as I said, have really been also explored, but then unfortunately, the research, around omega-3 fatty acid have come out with, mixed results. So, and of course, one of the main reasons for the use of omega-3 fatty acid when it comes to fat, besides the fact that fat is a good source of energy, a lot of wears and tears happens, during injuries, or when athletes are, during injuries, and when athletes are recovering from injuries, there are quite a lot of inflammation. And because of its anti-inflammatory effect, it's really have been explored. So studies have shown that it also increases protein muscle synthesis, okay, when omega-3 fatty acid is supplemented. However, as I said, other research have also indicated that it impairs wound healing. Okay? So when it comes to the fats in injury recovery and rehabilitation, there is the need for more research, to guide the use of such supplements when it comes to that. And of course, the common sense approach you would take would be to make sure that they are actually deficient, so the athletes actually need it, okay, before you go ahead to recommend, because of the fact that, as I said, other research is saying that it is not helpful, and that it actually, what it does is that it impairs. When it comes to micronutrients, these are some of the micronutrients that have actually been shown to be beneficial when it comes to rehabilitation, especially when it comes to bone health. Okay, so but then, as I said, research have not shown that beyond absence of deficiency, whether it helps, right? Yeah, whether it helps, whether beyond absence of deficiency. So if the individual is not deficient, or if the individual is able to meet, that through their normal diet, giving it, more supplementing may not actually show any beneficial effect. Due to time, probably I'll just skip the hydration part, and then conclude by saying that nutrition plays a critical role in sports injury and rehabilitation. And proper nutrition provides the necessary fuel and building blocks for optimal recovery and performance. Through a balanced diet, athletes can enhance their healing process, reduce inflammation, and then support tissue repair. Key nutrients such as protein, carbohydrates, fats, vitamins, and minerals contribute to the repair and regeneration of damaged tissue, strengthening the immune system and reducing the risk of future injuries. Additionally, maintaining hydration levels is also very essential for proper nutrient absorption overall performance. Hence, by incorporating a personalized nutrition plan into their training program, athletes can actually maximize their recovery potential and return to their sporting activity faster. So thank you very much. Yeah, this brings me to the end of my presentation. So thank you very much.
Thank you very much, Dr. Van Hefford. I mean, you also owe me a lunch for my 5 minutes, but thank you very much for such a presentation. I'm sure we are learning so much, and we are getting to know the lapses. We are getting to know all the lapses that we have when it comes to sports. The next presentation is going to be done by my very good friend. Okay, I think Professor Suman wants to make a comment. Prof. Chair, please, the floor, it's yours.
No, George, I was just congratulating the presenter. Thank you.
Thank you very much, Prof. I think that the next presentation is going to be done by my very good friend, Dr. Abna Tando, and she's going to do something on rehabilitation. He's going to do something on rehabilitation. Dr. Abna Tando is an experienced and dedicated sports, exercise, and rehabilitation doctor with over 14 years of experience in rehabilitation, including the provision of service for para athletes. She is the training coordinator for sports, exercise, and rehabilitation medicine training under the Ghana College of Physicians and Surgeons, and also lectures students in disability and rehabilitation at the Kwame Nkrumah University of Science and Technology. Dr. Tano established the first multidisciplinary rehabilitation medicine service in Ghana, which has improved the function, independence, and quality of life of persons with disabilities. She is adept at conducting assessments and managing common health conditions in sports, and has a proven track record in developing curricula, protocols, and training manuals. Dr. Turner is a member of the American College of Sports Medicine and instrumental in the organization of the American College of Sports Medicine's first international team physicians course in Ghana. She currently consults for WHO and other international organizations. She will be doing the topic on rehabilitation of sports injuries. Kindly help me invite Dr. Abna Tando as she takes a position to give a lecture. Dr. Abna Tando, kindly take over.
And I hope everyone can hear me. So today we're going to talk about rehabilitation of sports injuries. And before I continue, just to give a disclaimer that I work with the WHO, but the views expressed in this presentation are solely mine and do not necessarily represent the views of the WHO or any of its affiliated organizations. And the presentation is being made in a personal capacity and will not be attributed to the World Health Organization. So we'll just continue. Brief outline, we're going to talk about the introduction, the stages of rehabilitation for sports injuries, the protocols involved, and how to make rehab effective for sports injuries. So we all know that there are different sports in different types of sports, and there are different injuries that happen in sports. Actually, evidence shows that the majority of injuries occur in soccer or football. And I guess that's one of our major sports in Ghana. And so we may see a lot of injuries associated with that. But that notwithstanding, that different injuries can happen with any of the sports we are involved in. So what is rehab? Rehabilitation is basically dealing with functioning. Anything that it's a field of medicine that tries to get people to go back to how they were moving, how they were functioning before that injury happened. So rehabilitation is basically about restoring function or bringing someone as close as possible to how they were before then. Now, what are the goals? Usually with sports injury rehab, we are looking at limiting the extent of the injury, making sure to see whether we can reduce or reverse that impairment or loss that happened to the person's function. And ultimately also to prevent, correct, or get rid of disability altogether so that that person does not end up living with a disability. But whenever you are dealing with a sports injury, a person who has sustained a sports injury, setting a goal is very, very important. Because if you don't set a goal, you don't have an endpoint, you don't know what you are working on, you don't know the kind of exercises. You have to ask yourself, does the person even want the rehab? Does the person want to get better? Does the person want, maybe what the person's goal is unattainable, or maybe what the person wants does not actually, that is not what you can provide for the person. So you have to set a goal with the person, because it also gives you a sense of control and also gives that athlete a sense of control. It enhances motivation, commitment to it as well. You are able to bring in new strategies because you want to hit that goal you have set together. And also ultimately it promotes a greater satisfaction, because once you set a goal and you attain that goal, then that athlete is satisfied with that. Now, there's always teamwork. Teamwork in sports, teamwork in rehab for sports. If a player gets injured, obviously the player is the most important person. But you are looking at the coaches. They play a very important role in what happens to the player after the injury, because the coach will be putting pressure on you as the person who is handling the rehab, that I need this player to get back to playing as soon as possible. They are putting a lot of pressure on you. Sports scientists, those involved in biomechanics, nutrition, we've heard about it, psychologists, they are very, very important. And obviously the medical team, a sports physician, a rehab physician, and a physiotherapist and other rehab professionals are also important in managing sports injuries. So let's look at the stages of rehabilitation for sports injury. Usually there are three main stages. Other references have other stages, but there are three main stages. We have the initial stage, which is the inflammatory stage, and usually lasts about a week. Then we have the intermediate stage, and then we have the advanced stage. In the initial stage, and we'll go through some of the things that are needed to be done, there are interventions. The inflammatory stage, you are looking at bringing down the inflammation, starting a couple of exercises. And if you don't do that well, you don't tackle that well, the person is going to end up with muscle atrophy, muscle weakness, some limited joint range of motion, and eventually disability. So the inflammatory stage or the initial stage is very, very important. Then you come to the repair or the intermediate stage, where you also go on with the exercises and you increase the intensity and the duration of the exercises. If you don't work on that well, also, the person is going to end up with delayed repair, delayed recovery. Then we have the advanced stage where you have the remodeling, you're conditioning the person to go back to playing. And in that stage, again, if you don't work at it well, doing the functional training, the sport-specific exercises, the person or the athletes can re-injure themselves. And there's a tricky situation here where in the advanced stage, the athlete feels that, oh, I'm much better, so I don't need to continue with my rehab. And that's where there's a higher chance of they getting an injury again. So this is just to show that they overlap. There isn't really a strict phase for inflammatory to repair to remodeling. There is some bit of overlap. So every injury is different, every patient is different, and you have to know how best to tailor the rehab according to the injury and the kind of athlete you are dealing with. And before you start, there has to be, remember I said it's a teamwork. There has to be a team discussion, including or involving a sports or rehab physician who can also advise based on the knowledge on the body function and the medical conditions involved before any regimen is started. Don't start anything without that consultation and team discussion. Otherwise, you cause more harm than good. So let's look at the stage one. We've talked about the price, and I'm sure we all have an idea. If somebody has an injury, you want to start by protecting that area. Usually it's a joint or a bone or wherever. You want to protect it. You want to give that a bit of rest in that injured area, applying ice to bring down the inflammation. If there's some swelling, compressing to bring down the swelling, and also elevating that limb or that area to bring down the swelling as well. And when we look at pain management in this stage one, in terms of acute, non-pharmacologic, you want to, if there are dislocated joints, early reduction. There's a lot of immobilizers, splints, braces, casts, and all taping, wrapping, and these are all available in Ghana. And based on the injury, depending, and sometimes you have to consult with orthopedic surgeons also to determine what kind of immobilizer to use as they await surgery or as they move on with rehabilitation. Now, in as much as we immobilize, please bear in mind that there are effects of immobilization on the athlete. Some people tend to immobilize a joint for a long time. I've seen cases where an athlete has a sprained ankle and that athlete doesn't move the ankle at all, is sitting at home, the ankle is wrapped or in a cast, or nothing happens to the joints below or above the ankle joint, no exercises, nothing. And by the time that cast or the brace or the splint comes off, there's a lot of muscle bulk loss. And then there's this added extra work of having to bring or build the muscle. So bear in mind that in as much as you have to protect the joint, and we'll come to the kinds of exercise, you need to also start. Remember I said that even in the acute phase or the stage one, exercises start at well, but it is not every kind of exercise. We'll come to that. So bear in mind that within 24 hours, that athlete will start losing muscle strength. The cartilage begins to decrease in thickness, begins to soften within a month or 30 days. There's weak or joint instability to the ligaments become weak. Within 2 weeks, bone loss starts. And also there's detraining. After 1 to 2 weeks of normal activity, that that athlete starts to detrain, so that the body is like you're going back to square one after all that period spent in training for that particular sport. So the solution is early remobilization. It's important. And before we go on to that, we want to look at the fact that there are so many medications that can help also to manage the inflammatory phase and the pain that comes along with it. And we can do topical or oral. We have acetaminophen or paracetamol, NSAIDs. There are some beliefs that NSAIDs inhibit healing, but some evidence have come up that shows that NSAIDs don't really inhibit healing. And usually if you combine that with acetaminophen, there's better relief. But muscle relaxants, actually, there's poor evidence that they actually cause skeletal muscle relaxant effect. So when we talk about the inflammatory phase, even when it's just happened, you are trying to do the price, protect, rest, ice, do the compression and elevation, you can start with gentle pain-free range of motion exercises. So when we talk about passive range of motion exercises, the health professional, you are holding and gently moving that joint gently, or they are doing active assisted where they are using something to help them to move that joint, or they are doing it by themselves. The range, the joint before or after that injured, if it's mainly, let's say it's an ankle sprain or a knee joint injury, you can still move or gently mobilize the joints proximal and distal to that injured area. So it's important that you start moving the joints. And then we look at isometric exercises. If there's an injury, for example, if you look at the second picture, isometric exercises basically involve not moving a joint, but being able to exercise the muscles surrounding the joint. So if you look at the second picture of the man sitting down on the ground, they have that exercise can be done for someone who has sustained a knee injury. So you are not moving the knee joint, you are not bending that knee, but you press or you stiffen or you contract the muscles surrounding the knee by trying to sort of push your leg down further into the floor. So when you do that, the muscles contract, the muscles surrounding the knee contract, and they strengthen or they support the knee better. So these are exercises, isometric exercises that can be started immediately after an injury to be able to build the muscle or keep the muscles built without losing muscle bulk. Now we look at the stage 2. In the stage 2, you continue, that athlete has to continue with the flexibility and joint range of motion exercises, where in this case, they are putting more effort into moving that joint. Usually after maybe there's a surgery has happened, after a week or two, when the inflammation has gone down, you start by moving the joint. But bear in mind that every injury has its protocol. And we'll come to examples of that. So you have to know the exact protocol and the severity. That these protocols also are based on the severity of the injury. So moving the joint is very important when an injury happens. You don't leave it like that, because remember, immobilization will cause more harm than good. But it's at a stage where it's in the stage 2, when the inflammation has gone down, when the pain has gone down, you begin to move the joint. And in the stage 2, again, we are looking at strength and endurance exercises. So isotonic and isokinetic exercises, you are moving the joint itself, but you are also adding a weight to it such that you are building the muscle, you are improving the strength, you are strengthening the muscles surrounding that injured area. So it's important that, remember that stage 1, you are not adding any weight to, you are not moving or lifting any weight, but you are contracting the muscle so that you build the muscle bulk. But in stage 2, you are going ahead to add a lot of weight, you are moving the joint and building the muscle bulk further. The stage 3 is more functional rehabilitation, sport-specific rehabilitation. So after you've started stage 1, you've started with simple exercises, gentle, pain-free exercises, strengthening exercises where you don't move the joint, and then you move to stage 2 where you are now moving the joint, where you are now doing a bit more intensive exercises. Now you come to stage 3 where you are doing exercises that are related to the kind of sports the person is engaged in. So if it's football, like in this picture, you are looking at exercises dealing with balance, dealing with kicking of a ball, being able to balance on one leg and catch a ball, being able to hop on one leg. So all these are functional specific rehabilitation exercises or sport specific rehab exercises. Now we're coming to look at some examples and see how the rehabilitation goes for them. We look at head injury. That is one of the things that a lot of professionals tend to forget or tend to brush aside. So you have an athlete who, after colliding with an opponent, a football player, momentarily stands, saw stars, had blurred vision for approximately 30 seconds. After 3 to 4 minutes, the individual reports feeling much better, except for a slight headache. And one thing I'll say here is that if you are a professional who is involved in sports, you need to be, when you are on the sidelines on the field, your eyes have to be on the players. You have to watch them, because knowing the mechanism of the injury would help you better to tailor the exercises or the rehab. If you are not there on the field and an athlete comes around, let them be able to explain, or as much as possible, what actually happened, so that you have an idea of the kind of injury. So when we look at common head injuries like this one, you might tend to brush it aside, but there are some people who can collapse afterwards, who can suffer extensive injuries afterwards. And we would have one of our consultants talk to us about head injuries later in the second session. So when we look at concussion, it's basically a traumatic brain injury that affects your brain function. It's like your brain shakes in the head. And usually it comes with different kinds of symptoms: blurred vision, confusion, difficulty in paying attention, orientation, and sometimes even vomiting, in dire cases, in severe cases, collapsing or becoming unconscious. So all these are things that can happen with just head-on collision with another player when you are both trying to head a ball. So in such a case, you don't just get that person, there's a skill. And let me just go back. I just put it here because we are actually talking about rehab, so not really about the assessment. But the SCAT-5 tool is a skill that is widely used by FIFA with the Olympics, every place, to assess a concussion. It's a simple tool. You can read up on it and be able to determine if an athlete has suffered a concussion or not. So we are looking at return to play after a person has suffered a concussion. And you are looking at the fact that they cannot immediately go back to play, or in the first 1 week. There's a stepwise or graduated return to sport strategy. So you start with getting them to be involved in daily activities that do not provoke their symptoms. If it's blurred vision, if it's headaches, if it's dizziness, if it's feeling like they are not balanced well, they are going to fall, if it's nausea, you want them to be able to go past being able to do their daily activities without provoking symptoms. And then they move on to walking or stationary cycling at a slow or medium pace, no resistance training involved. So that is one thing that you have to also work on. And then there's a stage where you move on to running. No head impact again till you get on to the harder training drills, and then you move on to full contact practice. And then you move on to the normal gameplay. So there are stages to coming back to play, even with a concussion, with a head-on collision, where they meet the concussion criteria. Now let's look at shoulder. And with the shoulder, sometimes we usually think that, oh, it's in the elderly or someone who may be manual workers. But sports players, those who usually play tennis or do that overhead sports, even if they are young, can come with shoulder injuries. So we are looking at a 15-year-old elite junior tennis player, has been playing for a couple of years, comes with a 2-week history of right posterior shoulder pain, no swelling or redness in the area, and the pain has gradually been increasing over the period. And she denies any recent changes in technique or training volume, no neurologic symptoms, meaning no numbness or tingling in the arm. And she rates her pain as consistently 8/10, complains that her shoulder feels weak and tired during sales and overhead activities. So this is someone who you have to take seriously. They are players, they are sports person, even though they are young, even though there's no neurologic symptoms, but she still says that her pain is 8/10. Don't brush it away. And she feels that it's weak. So you need to examine. Most likely it is a rotator cuff tear. And in rotator cuff tears, you have, it's like a slight tear in the rotator cuff muscles. So you are looking at pain in front or side of the shoulder, which is aggravated by reaching or overhead activities. There may be a precipitating event. Sometimes there's no precipitating event. So don't brush it off again when they say that. You ask, did you fall? Did you hit your arm, shoulder against something? They keep on saying, no, don't brush it off. The history of the fact that they've constantly been training, they've been constantly playing, means that it could be a tear. And usually unable to elevate the arm from the side. An MRI is the best diagnostic tool, and it helps to be able to confirm that it's a rotator cuff tear. So when it comes to the rehabilitation for a rotator cuff injury, usually you want to start, remember that we said for in the initial stage or the first stage, you want to still be able to move the joint, but gently pain-free. You want to be able to strengthen the muscle, but without moving the joint. So when you look at all the first row of exercises, you are not lifting the arm up, but with what the exercises involved, you are still will be able to strengthen the shoulder joint. So these are exercises you can do in the first 4 weeks. And then when you move on, you are going into more intensive exercises where you are lifting the shoulder, you are lifting the arm up gently, sometimes active assisted or doing it yourself. And usually I like it when they can hold the rod and use that to lift. So then the normal shoulder is helping the other shoulder, or intertwining the fingers and lifting the arms up. And then using dumbbells, still doing the strengthening exercises. Again, you don't want, use the pain to guide. You don't want that person to be in pain when they are doing it. And usually between 8 to 12 weeks, you are trying to get that athlete to gradually return to functional activities. So that's when you do more of the push-ups and a lot more of intensive exercises for rotator cuff tear. There are some of the things that we've been doing for a long time because of probably something you've seen, but are not evidence-based. So things like scapular taping for a rotator cuff tear. There's limited evidence to it, and the advice is to use sparingly. It is not the main treatment modality for rehab. It's the exercises you have to work on. Ultrasound therapy does not help. same as infrared laser or TENS or electrical stimulation. There's no evidence that they help with rotator cuff tears. So please let's work on the exercises more. Now let's look at knee injuries and how to go about knee injuries. So we are looking at a 20-year-old female footballer who lives with pain and swelling in the left knee. So the patient was injured during a recent Black Queens games when she planted her right foot, changed direction to go around a defender, and note the mechanism. It's like a pivoting and turning injury. And she had immediate pain in her knee, attempted to walk off the field, but experienced a giving way episode and had to be carried off the field. On the sideline, she noticed significant knee swelling. And when you examined, you realized that there was limited range of motion and painful knee flexion with joint effusion. And when somebody gets a knee injury, and I'm sure the next session we'll talk about the investigations and other things. I've had so many instances where a coach will say, oh, let's go take an x-ray. Unless you're suspecting a fracture, x-ray will just help to rule out a fracture. But if it's a ligament tear, if it's a meniscal injury, your best bet is an MRI to just be able to visualize and see. Because if you take an x-ray and the x-ray says there's no fracture, and meanwhile there's an existing ligament tear, you are doing more harm than good to the athlete. And that athlete may not be able to return because you say, oh, it's just swelling because, or maybe a bruise, or it's just a contusion of the knee. So you get better, and you get better, you get better. And that athlete's career, it ends because they cannot go back, because what exactly is the problem there has not been noted. And usually there's the excuse of, oh, there's no money, but you consider the career or the function of that athlete to the cost of an MRI and try to see how best you can actually help with this athlete. So if you do, if it's an ACL tear, we are coming to look at, and most likely looking at the mechanism of injury for this athlete, it's most likely to be an ACL tear. And we are looking at what are the indications and what would you immediately begin rehab. For an ACL tear, immediately begin. It's not everyone who would need surgery, but if that person has joint instability, if they are involved in sports or in jobs that require pivoting, turning, or hard cutting, or there's a young child or an adolescent, or there are combined injuries, maybe there's a meniscal injury as well, you want to do surgery. But aside that, if that person is engaged in normal activities, then you don't need surgery. But even if surgery is recommended, you need to start with those stage 1 exercises as soon as possible before the surgery happens. So this is just an example to show that there are protocols for rehab for each of the injuries. Don't just decide to start with any exercise as you like. Follow the protocols. This is one. For ACL injuries, it takes a long time, usually more than 8 months, at least 8 months, to get that player to go back to playing. So don't just say that after 6 weeks or after a month, after 2 months, oh, I think you're fine, you can go back. Don't let a coach also put pressure on you to say that, oh, this player can go back. Let's just give a lot of painkillers and get him to go back. No, you are causing more harm than good. Follow the protocol. And then we'll look at an ankle injury. We are looking at a 17-year-old basketball player who stepped on an opponent's foot and had the left ankle inverted and developed lateral ankle pain with associated swelling. So there's pain with weight bearing and denies popping or clicking. So we are looking at how best to rehabilitate such a patient. And we are looking at the grades of a sprain. So we have grade 1, grade 2, grade 3. And you have to look at how to rehabilitate the different grades. So when this is a photo of a normal sprain, and then you have a grade 1, a grade 2, and a grade 3, which is like a complete sprain. So when we are looking at the rehabilitation, it has to be for the grade 1 and grade 2, early mobilization and functional support. So for all the grades, you need to immobilize to tape. So sometimes for grade 1, grade 2, you would tape. For grade 3, you would most likely, if it's a complete tear, you want to do a below knee cast or a rigid brace. But again, remember the Price principle, the Rice principle cuts across. There's no evidence again for electrical stimulation, therapeutic ultrasound, the laser, the shortwave diathermy. It doesn't work. But weight bearing can start up to 2 weeks with protection. Afterwards, you can take off the protection. For grade 1 and grade 2, you start immediately with the range of motion, the stretching, the strengthening. And for the grade 3, you can wait with the strengthening, delay it for about 4 weeks before you start the strengthening exercises. Recovery period ranges depending on the grade from 2 weeks to for grade 1 to 4 to 6 weeks for grade 2, and then as long as 12 weeks for grade 3 ankle sprains. So this is also an extensive protocol that takes you through exactly what to do if somebody comes with an ankle sprain and the rehab. But this is mainly for a grade 1 and a grade 2. So bear in mind that there are specific exercises that have to be done when it comes to rehab. For want of time, because rehab for sports injury is very extensive, I cannot go through each of them. But bear in mind that there are protocols available for each grade and how to manage them. And we are looking at how do we make rehab. Yes.
Please, you have 5 minutes. Thank you.
Sure. So how do we make rehab effective? Rehab, to make it effective, it is not just about managing the impairment. You have to look at the personal and environmental factors as well. So this is a case study, but to cut it short, it's a football player who is playing for Black Stars, has been training, wants to play in World Cup, and then sustains an injury to the knee. His family, everyone is putting pressure. Charlie, he's going to play for World Cup, and everybody wants to watch him. Now he can't play, and he's feeling so down. He also lives on the 2nd floor where of the flat where he is in. And we want to, aside, we've talked about body function and structure. We are looking at the activity, we've looked at that. I want us to concentrate on the 2 bottom areas, the environmental factors and the personal factors. How is this person going to climb the stairs in his house? How is he going to drive if he drives? Is he feeling low? Is he feeling depressed? It's very important that you consider those factors as well. And the personal factors, there are so many factors that affect a person's reaction to injury, in terms of their self-esteem, the social support that is available, how their coping mechanisms. So look at that. And also their relationships or situations around them, maybe the sports of their life, that is what is paying their bills. Maybe they have their relationship with their coach, that also plays a very important role there, and their role on the team. To be able to assess for depression, there's a simple tool, the patient health questionnaire tool. It's just asking 2 questions, and a score of greater than 3 requires further investigation, and so, or referral to a psychologist or a psychiatrist. So please be abreast with that. And usually, if you are managing a person like that, constant education about the injury and the recovery process, motivating them, encouraging positive feedback, and education on relaxation techniques is very important again. And just to about ending, how do you return a person to play? There's return to participation, return to sport, return to performance. All these are based on how active or how that person has recovered through the rehab process. So they start by participating, return to participation, then they go to return to sport, then return to performance within the sport. So before that athlete returns to play, that athlete needs to pass the fitness standards of the team he's returning to. And if you are part of a team, if you are part of whichever group it is, make sure that you have standards and make sure that that athlete passes that test. Please, not just because that athlete needs to win a game. And so, or that athlete, even if that person, your patient you are seeing, is not involved in any big sports, but is just goes for walks or runs with a couple of friends in that area, make sure that before that athlete returns to that weekend jogging up the Ebri Mountains or Equiape Mountains, they fulfill the standards. Because especially for those involved in team sports, now there's a lot of legal issues coming up. In the US, late last year, a medical consultant was fired because a player had a concussion. They cleared him to go play when he hadn't recovered fully, and when he collapsed, they fired him. So please, when there were complications, they fired him. So please be careful. So in summary, rehab plays a very important role in the management of sports injuries. Don't just stop at the acute management. And if there's surgery involved, you have to do prehab. It improves the outcome of the surgery and of the rehab. And then always consider the person's engagement in daily activities, their participation restrictions, their environmental and personal factors is very important. And lastly, their spirituality. In Ghana, spirituality plays a very, very, very big role in sports and also in rehabilitation. So for those, the Bible says in Isaiah 40 verse 31, but those who hope in the Lord will renew their strength. They will soar on wings like eagles. They will run and not grow weary. They will walk and not be faint. And that's one of the things that some of the players also use to encourage themselves that they will recover and their rehab will go well. Thank you very much.
Thank you very much, Abner, for such a brilliant presentation. I mean, one word is that please make sure that if you are in this business, you don't get fired because you didn't do things right. And make sure that your, patients and your clients can't play for long. If you do not make sure that they go through the rehabilitation process, then you can be sure that they may not be able to go long and play for long. Thank you very much, Abner. Please kindly put your questions in the chat box. We have a lot of interesting questions, but before we ask that, and we ask these questions, we want to ask Mr. Farm Courage Zorono from Hill Pharmaceutical Company Limited. They are helping us with this program. He's presenting something special on nutritional support in healthcare, especially in sports medicine. We are doing sports. I want to, they have some products that we think that will be helpful to us. So we'll be presenting on this topic whilst we put together the questions. Thank you. Courage, please take the stage.
Thank you very much, Dr. Nketiah, for the opportunity. Yes. We are grateful for this opportunity. We will be talking about a range of products, but largely we would eventually focus on the product that we'll be using largely for managing not just injuries in sports, but also in other conditions as your practice you may come across during your practice. Yes, so we'll be talking largely about nutritional support in healthcare management. But before or as part of that, And also I need to introduce these other products that we have. Aside what we'll be talking about, you can see some TPN picture on your slides. Basically for those of your patients who, of course, that will be in the hospital settings where they are not able to feed, or they have critical medical conditions, or those who have gone to do some form of surgeries for which they are unable to take anything orally or enterally. Meanwhile, you still want to feed. We have this TPN, it's called carbipen. So it contains amino acids. It gives you your glucose and of course your lipids as well. So you can see that amino acids would give you have about 51 grams of amino acids, your dextrose, and then the lipids. And a bag of 1,500. So we will have to put in, it's technically 1,500 because when you are running the infusion, you would have to leave a little for priming your lines and those other things. So you would have 51 grams of amino acids, dextrose, and then some amount of lipids as well, with some vitamins. Then aside that, we also have what we call aminovin. So this is exclusive amino acids, for which 1 gram, 1 liter bottle will give you 100 grams of amino acid with very high levels of bioavailability. So sometimes some people decide to, depending on what you are managing, if you are looking at very high levels of amino acids, then you are looking at the aminovin that, like I said, it gives you 100 grams of amino acids. But if you are looking at the amino acids, the dextrose, and then the lipids, which is more of a total parenteral nutrition, then you are looking around 50 grams of amino acids together with the dextrose and the other lipids. So like as I said, depending on what we expect or what we want to manage, sometimes some practitioners, what they actually will do is they will alternate between the TPNs, which is the carbipen, or they run the amino acid solution. So anyhow that you want to, depend on what you are looking at, both of those are available. The aminovin, which is amino acids, we have for adults and then we have for the children as well. So now back to, so those are just brief introductions on the TPNs we have. We currently have in here we have it in Kolebu actually, or let me say the facilities in Accra. We should be in Konfanoche soon, and then most of the other regional hospitals too will be coming across. So just as and when we are coming to your facility, we'll get you to be aware so that you can join us for those presentations and also recommend it to the numerous patients you attend to. Now you agree with me also, now we want to talk about oral nutritional supports in healthcare management. So we are just not limiting our presentation to persons who have sports injury. Of course, most persons, before they even get to hospitals, have some form of malnutrition in this part of the world, for which their medical conditions also even aggravate, or yes, it aggravates their nutritional status. Some persons, once they're in hospital in the first place, the disease condition is not able to let them feed well. The disease is also depleting excessively the stored nutrients that they already have. So you agree with me that for most people who are in hospital, and for that matter, whichever condition you are managing, you agree with me that most of them will need some form of nutritional support. As much as relatives bring some food and all of those things, you agree with me, for most of the time, what they are able to take but what the relatives bring are not very much. So nutritional supports are very, very important in managing healthcare conditions, especially in our healthcare facilities. Now, before you initiate any nutritional support, you, of course, together with your dietitians, you would want to do the necessary assessment to tell what your patient would be able to tolerate. If, of course, if it's the case that the GI of the patient is not functioning, then you are going outright for the TPNs. But for those who can tolerate something, maybe you are doing an NG tube feeding or you are doing oral nutritional support feeding. Anyhow, it's fine. So clinical consequences of malnutrition include reduced muscle, frailty, increased risks of falls, recovery, slow recovery from ailments, and of course, most of the time, it leads to significant loss of lives. And also most of the time, in case, especially for conditions of surgeries, there is slow recovery when it comes to persons who have had extensive surgeries and don't get any proper or scientific nutritional support. It slows down the recovery, and for that matter, they stay longer in hospital. So by the time you add the cost of the stay in the hospitals and all the other things, you realize that when you introduce nutritional support there early enough, that's the point. From the experiences also we've had, we realize that from the experiences we have, we also realize that most practitioners will recommend nutritional support at the later stages. But for us, it's also been proven that for conditions where, or for cases where the support comes in quite early, it's very helpful. So we are also appealing to the practitioners that as much as possible, let's introduce nutritional support to your clients early enough to help them get the recovery as early as possible. So of course, just indication for enteral nutrition, poor oral intake, unsafe oral intake, maybe persons who are vomiting, persons who are having extensive difficulties swallowing, then under such conditions, you can't do oral nutritional supports. And of course, elevated needs can't also, that's for persons who cannot eat. So when your patients fall under these conditions, then you want to look at enteral feeding. Now for oral nutritional support, like as I said, that when the person at least can take something orally, then you would want to introduce the nutritional support orally. Now for us, we have this product we call we have this product we call First Choice, yes. So we have this, it's called First Choice High Protein Recovery Milk. These are low-fat based high protein milk. So you can see on your screen, it's a 250 ml bottle. It's a paper pack actually, which gives you 21 grams of protein. So for most persons, the truth of the matter is, whilst again in hospital or even persons who are recovering from ailments are not able to even take large volumes of any item. So if you have a product that just 250 ml will give you, or if you have a product that has a high concentration of protein and then significant amounts of carbohydrate to give you the needed energy, I think it would be a great support. So like as I said, you would get 21 grams of protein in a 250 ml pack. Also, each gives you about a little over 200 kilocalories of energy. Okay, so each gives you about 200 kilocalories of energy as well. So between 2 to 4 packs a day should give you about 400 to 800 kilocalories a day, which is quite significant. So for persons who are even on some form of NG tube, we recommend you can mix it with, if it's a mashed kenke or any gel or any other thing, you can mix it with it. And like as I'm saying, for just 250 mils of the high protein milk, you are getting about 21 grams of protein, which is, you agree with me, it's really significant. It also has 8 B vitamins with some significant amount of calcium, as a matter of fact. So high protein contains 21 grams of protein, which is more than twice the amount of regular milk. Protein supplies building blocks for growth, repair and maintenance, It also plays a vital role in supporting the immune system, helps to make hormone and transport nutrients in the body. Like as I said, high in energy, 8 added vitamins, high in calcium as well. And so you also have the proteins as whey and casein. So casein constitutes about 80%, and then the whey components about 20%. You know, normally for persons who take the whey milk or milk products and have a lot of diarrhea are the ones that the whey content is much higher, because the whey is readily absorbed whilst the casein is absorbed slowly. So you realize that in this product, the casein content is rather 80%, whilst the whey content is 20%. So incidence of excessive diarrhea is very much limited. And on this score, what we normally recommend is for persons who are supposed to take it for the very first time, just let them take about half. After another 2-3 hours, they take the extra half. After the first 24 hours, the diarrhea contents or the incidence of diarrhea is greatly reduced. So you just have typical nutritional information on the slides, as you can see. So we have the chocolate flavor, we have peanut butter, we also have banana flavors. I think very soon we also adding strawberry with vanilla flavors very soon. I'm sure by July, August, we should get those bits. And also, it's aside those who are in hospital, we're also recommending it for patients who are recovering from ailments, the aged. Children above 3 years can also take it. And of course, for sports people who are also involved in sports, they get the protein to help rejuvenate or to help replenish their loss when it comes to the muscles, and also good amount of energy to help replenish their energy loss. So for the sports nutritionals, of course, there's a lot that has been said about this one, so I wouldn't want to belabor that point. So for what we are discussing today, in short, we bring in this product. In fact, it's already available in the market. It's called First Choice HPR. HPR just stands for high protein. So for all your clients who come across, either on your wards or the OPDs or wherever they come to your consulting rooms, you want to recommend First Choice HPR. Like I said, First Choice high protein milk for them across, and they will find it very useful. Thank you very much. Then we just want to run some other range of products that we have. I'll be very brief. I'm told I have just like 5 minutes. These are, 1 minute. Okay. So we do some products from Fresenius Kabi, South Africa. That's we have some fentanyl, we do betadine, highly controlled, morphine preservative free. We have sanxametonium, neostigmine, we have IV paracetamol, we have propofol, we have 1% and the 2%. Then we have some other cetirizine tablets, azithromycin 500 milligrams, CoxB, that's our brand of celecoxib, which is a very popular brand. And you can, for those who have experienced it, know that it's a brand that works so well. The Olopan, that's our olopatadine eye drops. Asimazole, salbutamol, Optin, yes, well known. That's our esomeprazole. We have the 20 and the 40 milligrams. Levofloxacin, Cadovac, that's our nifedipine 30 milligrams. Beltocin, that's our oxytocin. A very good brand, I must say. Clindamycin, we have the injectables and the capsules, the 300 and the 150 milligrams, which is widely used in most facilities across the country. Mipirocin, Trego is our Noki, that was our vecuronium. So just the Exonase, that's our injection esomeprazole. So in the various facilities where you want esomeprazole that works and works well, for which the price is also very affordable. You are looking at Esomix, Pregabalin, our Pregabalin. We have tranexamic acid, labetalol, all of those. So please feel free to get in touch with us at Hills Pharmaceuticals Limited. And of course, Eleron, it's one product that has been away for a very long time. And it's one brand that over the years have really helped in managing anemia in the numerous cases you've attended to. It's been away for a long while, but thankfully Eleron is back. So we currently have Eleron in-house. Thank you for having us. So the takeaway is first choice, high protein from Hills Pharmaceuticals, and of course the other products. So these are just our phone numbers on your screen. Thank you very much for having us.
Thank you very much, Courage, for this presentation. I hope that, when our clinicians and our sports people need it, they can find it. A few questions, because we'll be having a short break and coming back at 3. We just have 3 rounds of questions. So I hope my panelists are on. If they are on, they can unmute as I ask the question. So I think I've grouped all the questions for the various speakers. So I'll take Dr. Benedict Powell and ask all the questions so that they can answer all of them at a go. I'll go to Dr. Frank Hayford, and I'll go to Dr. Asman. Then I think there's a question for you, I'll also do that. So that's how it will go. So for Dr. Benedict Powell, says that what are the specific assessments? Are there specific assessments based on gender? Who is an elite athlete? And are there any local recommendations in screening athletes in Ghana? Because in your presentation, you made known that there are some specific ones for the European, there are some specific ones for the Americans. As a country, Ghana, do you have specific ones for us? Dr. Benedict, in just 2 minutes.
Thank you. And for the questions, the first question was about the special gender. We do know that there are some conditions that are more frequent in females. One is the used to be called the female athlete strike, but it's actually the red S, relative energy deficiency in syndrome in sports, which is characterized by menstrual irregularities. You have low energy with or without an eating disorder, and then the bone dysfunction, which predisposes to stress fractures. So in the history, it's one of the areas you screen. It can present with fatigue, the menstrual irregularities, and then also mental health issues can be very non-specific. So it's an area that you have to really look out for. We also know that females are at a higher risk of ACL injuries. And so you would want to have an eye on that in your MSK exam. The drop box test is a good one to actually sort of screen for that. It has an appreciable sensitivity. The athlete drops from a step and then immediately jumps, and then you're observing to see if there are any abnormalities. So there are a number of areas that we put extra focus on because they are females, and I think that should be that. There was a question about who's an elite athlete. Elite sports refers to professional sports. So anybody engaging in sports at the national, international level, professional, is an elite athlete, more or less, and it directly opposite to leisure sports, which is done for leisure, hobby, and in elite sports, the goal, the main things are about power and performance, as opposed to leisure, where you're talking about just participation and enjoying yourself. Really. Then there was a question about, I think it had to do with the ECG guidelines. The European guidelines say that they recommend ECG, and the US doesn't recommend ECG, and whether we would go for that in Ghana. The thing is, even in Europe, there are challenges with the recommendation because you need to sustain training of enough practitioners to be able to carry out the ECGs routinely. And even what we know is that the digital reporting softwares are better. They are more valid in terms of the reporting and differentiating between the physiological and pathologic ECG changes. And so, if we were to implement something like that, we need a certain intense infrastructure, like input, because you need to have the ECG machines, you need to have the modern software that goes with them. You need to train people to read the ECGs, and a lot of the problems you're going to pick up will be physiological, and most of the elements of your physical examination can pick up and rule out the major things you're looking for. So I wouldn't prescribe ECG as routine in our setting. We should do the health status history exam, and if there are any things pointing to cardiac abnormality, then step up to ECG, in which case the benefit would outweigh the cost and extra stress. We don't have standardized guidelines. Even the world doesn't have standardized guidelines. And I think as sports medicine the sports science is developing in Ghana, there's an opportunity for us to actually come together and have some form of standard for the country. Thank you. Over.
Thank you very much, Dr. Benedict Powell, for your answers. I want to come to Dr. Frank Paul Hayford. So he made mention of elite and recreational, sports people. So someone is asking, are there any difference in the nutritional needs for elite and recreational athletes? The second question goes like, we talked about some carbohydrate meals that replace, is there any Ghanaian carbohydrate meals that will replace the sports drinks that are used in carbohydrate loading during elite athletes engagements? So, a lot of times when we are watching most of these professionals, they have some drinks that they use and all that. So the question is that, do we have any Ghanaian carbohydrate that could replace that, so that when our black stars are going, we can have some Ghanaian, calm or meal that they also be using and showcasing the Ghanaian heritage. So are there any like that? Dr. Frank Hayford.
Yes, so thank you very much for the question. So I think I would start by answering that. So it will interest you all here to know that so there's currently one of our PhD students who is actually working on formulating such drinks using our local drinks because it's still ongoing. I wouldn't want to reveal exactly which of the local drinks he's currently working on, but he's working on formulating them, standardizing them, just like the energy drinks, we take the Gatorades and stuff. And I think 2 weeks ago, we had a discussion, and he was talking about the fact that, importing those drinks to sort of, run his study, is quite expensive. And I told him, of course, that is even the more reason why we need these localized drink here, because once we have them here, in terms of the cost, that might be, and he's actually, using, our usual local drinks. I think one of them probably is Asana also, trying to formulate and then come up with a similar, in terms of similar composition, in terms of what it does, like the Gatorade and the others. The second question being whether the nutritional requirement varies if you have to compare an elite and a recreational athlete. Yes, It does, but then in terms of the differences, it has to do more with the requirement. And as my colleague who answered the previous questions before myself mentioned, in terms of when we talk about somebody who is a recreational athlete and somebody who is an elite athlete, the distinction is that one is doing it at a very high level. So then that means that what that means is that it is in terms of their nutritional requirements, it may vary, right? In terms of what they need, their energy needs, the kind of competition or the kind of event they are involved in also would definitely differ because of the level at which they are doing. So they may have, in terms of the differences would be more on a requirement, okay? But as to whether, entirely, totally different meals, it may not be necessary, but I think the requirements may differ, right? Yeah.
Okay, thank you. Thank you very much, Dr. Frank Hayford, for your answers. Dr. Abner Tano, so this three comes to you. So somebody is asking how common are injuries in swimmers. I think some few, members of us are good swimmers and they want to know, I don't know whether they are also going to be the national doctors for our swimmers in Ghana, but they want to know how common, injuries are in swimmers. So they want to know, when athletes have injuries, what are there rehabilitation centers in Ghana that can support these athletes, and where can they be found? And I think just a comment, not a question. Somebody is saying that, as Dr. Abner Tano mentioned, when we are assessing people with injuries, we should do a full assessment so that we'll be able to know when the kind of injuries, the rehabilitation that they may need, and when they will return. Dr. Abner Tano, please, the two questions.
Okay, thank you very much. So in terms of the rate of injuries in swimmers, actually a study that was done in the US showed that when you take, there's an injury rate of 4 injuries for every 1,000 hours of training. And in females, you have about 3.7, 3.8 injuries for every 1,000 hours of training. So there's usually quite some form of injuries. And in swimmers, the commonest injuries are shoulder injuries because of obviously how swimming goes, or what's involved in swimming. But then again, the second commonest injury, surprisingly, is knee injuries in swimming because of, and it's usually related to breaststroke, kind of the style of swimming and the way they move the knees. So that's with the injuries in swimming. When it comes to, I think the other question that is asking about the rehabilitation centers in Ghana. So for injuries, there are obviously, most of the big hospitals have physiotherapists, but if you want a sports physician, we have myself in Kumasi, we have our trainees who are also being taught, the fellows who are training with the Ghana College of Physicians and Surgeons. So we have one in Cape Coast, we have some in Accra, we have some in Kumasi. So you can always liaise with us to see how best we can manage. If you go to any hospital where there's a family physician, they can also direct you to a sports, exercise, and rehab physician. And then there are teams, the big teams in Ghana also have physicians who are also experienced in sports to help. But mainly, now that we have the sports, exercise, and rehab medicine training under the Ghana College of Physicians and Surgeons, we do have sports, exercise, and rehab physicians. And our training basically encompasses sports medicine and rehab medicine training as well. And as I mentioned, we have physicians in Cape Coast, in Accra, and in Kumasi. And we always liaise together to see how best we can support. If you are in any other region and you reach out to us, we can also liaise with the rehab professional you have in your region to help with the management. And I think the last comment that was that, yes, MRI is expensive. And like Dr. Adumako mentioned, you have to be good at your skills in the situation where you don't have an MRI readily available. For example, if you have an ACL injury, if you know the Lachman test, the anterior drawer test, the pivot shift test, all these are tests that can actually give you a clear idea that I'm dealing with an ACL tear or rupture. So, and just to give a quick example, I remember when we were doing the GUSA games, where the Ghana University games, we had one volleyball player, female, who fell, landed on the knee. We saw the mechanism, so we kept insisting that this is most likely an ACL tear. The coach said that, no, we just do an X-ray. I said, you'll be wasting your time with an X-ray. I don't think it's a fracture. Eventually, we confirmed that it was. Eventually, when they went to do an MRI, it confirmed. And it was because we did the test. And also based on the mechanism of injury, we knew that this would most likely be an ACL tear. So please be good with your clinical skills. It will really come in handy. Thank you.
Thank you very much, Dr. Abena Tano. I think the last one is going to Hills Pharmaceutical. So I think that the product that he presented, people are saying that, well, with the things that are in it, it's going to be good. But what's the cost of this product? I mean, if they want to get it?
I think currently the retail price should be 30 cedis for one. That's how much your clients would get it. So from us, it's 24 cedis, but for the outlets, they should get it for a maximum of 30 cedis for one. Yes.
Thank you very much. I think that we've come to the end of the first section, because the second section is also going to be a 2-hour, 30-minute program. We want to give ourselves some 50 minutes to do some stretching. We're going to back 3:10 exactly to start the second section. We are going to do head injuries. We are going to do joint injuries and others. So kindly join us in the next 30 minutes. I mean, I don't think you should log off. You can just do some few stretching. And in the next 15 minutes, we are starting our next section. Thank you very much. Now we'll, join together to continue in the next 50 minutes at 3:10 exactly. Thank you.
Good afternoon. Good afternoon. Dr. Dalibo,
Hello, good afternoon.
please, are you on?
I am on.
Hello, good afternoon.
Good afternoon. Can you hear me?
Yes, please. Could you kindly share your slide?
Okay.
I just want to have a pre-run.
Okay.
Great. Thank you very much. Dr. Anand, please, if you are on, could you kindly try sharing your slides? Dr. Anand, please, are you here? Once you wait for Dr. Anand, Dr. Bako, please, I see you are on. Please, can you share your slides?
Yeah, I'm here. Hold on.
Thank you.
Is that coming?
Yes, perfect. Thank you very much, Dr. Bako.
Okay, thank you.
Dr. Anand, please, are you on? Fine, established. Thank you. So, Dr. Dadipo, please, I think you can have your first slide shown now. Thank you. Oh, yes. Hello. Yes. Thank you very much, Dr. Anas.
Coming.
It's about 5:30.
I can just keep on just receive the ultrasound report. They have doubt about it. They say, can you replace this with weight?
Wait.
Yes.
Okay.
Yeah.
Hello, good afternoon.
Good afternoon.
So it's currently 3:12, and we are going to start our second session. So to start with, we would have a presentation on an update on exercise and endurance medicine. It's quite important because I believe many a time in our practice as general physicians or family physicians, we advise our patients to engage in a number of activities to boost their health. And this afternoon, we'll be privileged to receive an update with regards to exercise and endurance. So to do us the honors on this subject is Dr. Benjamin Dadibo. Dr. Benjamin Dadibo attained his medical degree at the University of Medical Sciences, Kumasi in 1991. And having been a footballer all through his university days, he ended up being a team doctor for Kumasi Asante Kotoko in 1992. In 1994, he attended the FIFA Coca-Cola World Football Development Program in Sports Medicine, after which he proceeded to pursue a master's degree in sports medicine at the Queen's Medical Center, which is attached to the University of Nottingham. He's a member of the British Association of Sports and Exercise Medicine, and Dr. Dadibo has continued to complete his PhD in exercise physiology with particular interest in vascular aspects of estrogen, the interaction of estrogen status and exercise hemodynamics. Dr. Dadibo currently works as a locum registrar in the Ulster Hospital in obstetrics and gynecology. He is also an honorary visiting lecturer in the sports and exercise sciences at the University of Health and Allied Health Sciences in Hull. Dr. Dadibo is a Reverend Minister with the Master C Chapel International, Belfast, of the UD originating from Lighthouse Group of Churches. Thank you very much, Dr. Dadibo, for taking up this responsibility. And as done earlier, you'd have 35 minutes to speak to us. Thank you.
Okay, thank you very much for inviting me to be part of this. I think that the theme for this meeting is extremely valuable in the sense that we as doctors, no matter your field, no matter what you do, you come across people coming to you with injuries and how to manage them. I was drawn into sports medicine because when I was playing football with the players and we trained together, we go to camps together, and they will ask me all kinds of questions from dermatology to ophthalmology to whatever. So it stimulated my interest because I had to update my knowledge in order to be able to answer them. And so Dr. Abnatan has actually done a lot of the things I'm going to talk about. And so I would then focus on the mechanism or the adaptations to the neuromuscular adaptations to exercise and how it improves strength and helps in the rehabilitation process. So a quick definition of what sports rehabilitation is: the process involving a set of interventions aimed at optimizing function and to reduce disability in the individual, either with a health issue or injury, and for that matter, sports injuries. So the aim of rehabilitation is to carry out this process with the full awareness of all the factors involved to successfully return an athlete to the sports participation. And
sorry, Dr. Dadibo, it looks like we can't see your screen. If you could kindly.
Okay. All right. Okay. I thought. Let me. Sorry. All right. Okay. Let me share the screen. Great. Can you see my screen now?
Yes, please. We left with the slideshow. Currently, we can see all your slides. So we can kindly put it on the slideshow.
Excellent. Okay, so sorry about that. So we went through the quick definition of what sports rehabilitation implied and the aim of carrying out the processes with the full awareness of all the factors involved. And I like some of the points Dr. Abnatano mentioned, that it's important to note the mechanism of injury. It helps you to get the right diagnosis, and it tailors you to the right approach in managing. I've seen players who, there were some key players who got injured, and I made recommendations, advice regarding this rehabilitation, and you find out that coaches, managers would resist it. And then one day the coach asked me, if you say this player should not play, are you going to play? So it's very important for us to understand these principles. Now, so what is the importance of rehabilitation? It's I think Dr. Abnatano mentioned this. So the injury induces a deconditioning process, and then within a short time, the person's state condition of preparedness to play will greatly reduce. Then also there's also greater risk of re-injury or injury to another area when they return prematurely. And then also it leads to chronic longer-term problems, as Dr. Tano mentioned, that when the joint is not allowed to go through the full range of motion, it leads to the cartilage begins to have problems, and we tend to have chronic problems later on. Now, so what are the components of rehabilitation? And from the exercise point of view, we call it therapeutic exercises. The foundation for rehabilitation comes from these two, the flexibility training and strength training. Then upon that, you build on with endurance training, proprioception, and then agility, and then skills development. So that enables the person to come back to full participation. So again, it also depends on the person's state of condition fitness before the injury, and you try to match it and make it better so that he can return as quickly as possible. Now, so the process of rehabilitation starts with the price management, which has been highlighted already by Dr. Abnatano. So protection, rest, ice cold therapy helps decrease pain and inflammation. Then compression, gentle and even pressure is used in conjunction with the ice, and then also elevation to help with the venous return and blood flow to help with the healing process. So the topic given me was quite broad, so I decided to just use this. This is most questions that managers will ask you or supporters with when is this player coming to play? And there is no formula to be able to determine, but we are guided by principles. So this is a typical return to fitness or return to function based on knee injury. So you can see that, as Dr. Abnatano mentioned, there is an overlap. So you start with the ice, compression, elevation, and then use of protection crutches and so on. It starts from the onset of the injury. Then gradually the other components are coming, and Dr. Abnatano explained it very nicely with the various stages. So you see that this process continues until there's the important landmarks you see is when swelling stops, when limping, there is no limping, when swelling is gone completely. Then also you look at the range of movement that you achieve with the joints. So this guide introduces the various exercises where you have, if a heel cord stretch is a special exercise meant for the ankle joint that stretches the tendons and helps in the rehabilitation process. And you see that this process starts slowly, as you can see on the chart, and then it gets stronger and stronger and continues until even after the 100% function attainment. Then it also includes the various types of exercises, wrapping, isotonic exercises, isokinetic exercises, then springboard. These are all proprioception and skill development, fast walk, jogging and running, and then person is able to get back to full function. Now, so I have the disclaimer here. In fact, preparing for this, I felt that some of these things, when you talk about them, it's very difficult to visualize. So I found this, it's not my personal material, but it's just, I'm borrowing this video from Exeter the orthopedic department regarding how to rehab shoulder injury. And in the first 6 weeks, a lot of these things have been highlighted by Dr. Bernard Sano already. So so if you permit me, let's listen to this, watch this. The key thing is pain. You begin your process of shoulder rehab by asking the surgeon.
In the sling, we want to make sure that your elbow and wrist do not get too stiff. The following exercises may also help prevent blood clots in your arm by keeping your blood flowing. Gripping. While you're wearing your sling, open your hand as wide as possible, and then close your fingers into a tight fist. If your sling has a ball attached to it, feel free to use this for exercise. Perform this often and regularly throughout the day. If a ball is not provided, you can also use a small towel. Scap setting. Another exercise you can do easily in your sling is squeezing your shoulder blades back and down. You want to avoid bringing your shoulders up towards your ears or pushing your elbows backwards. Elbow passive range of motion. Sit upright in a chair with a pillow under your arm and to your side. Using your non-surgical hand, grasp the wrists of the surgical arm. Keep your thumb pointed up towards the ceiling. Bend your elbow so your wrist moves towards your shoulder. Then straighten your elbow out. Do not push through pain. Pendulums. From a standing position, find something roughly waist height and lean onto it with your non-surgical arm. Widen your feet. Allow your surgical arm to rest straight down without activating your shoulder muscles. Rock side to side while allowing your arm to passively swing like a pendulum. Start with a small motion, and as you feel comfortable, you can increase the motion. Remember to keep rocking your hips to move your arm. Next, stagger your feet. Shift your weight forward and backwards on your feet while allowing your arm to passively swing like a pendulum. Again, start with a small motion, and as you feel comfortable, you can increase the motion. This should be pain-free and performed regularly throughout the day. If this is painful in your shoulder, don't bend forward as far. Again, remember to rock your hips to move your arm. Shoulder flexion, active assisted range of motion. Lay down on your back with a pillow under your elbow. Grab your wrists with your non-surgical hand. Gently raise your arm up towards the ceiling, stopping when you feel pain. Come back down to your side and repeat. You can progress by raising your arm further overhead, but again, this should be pain-free. Shoulder external rotation, active assisted range of motion. Grab a cane or a broom. Stay on your back with a pillow under your elbow, resting slightly away from your body. Hold the handle of the cane with your surgical arm. Using your non-surgical hand, gently rotate your surgical hand away from your body, keeping a 90-degree angle at your elbow. Come back the opposite direction, again using your non-surgical arm to do the work. Isometrics. For the last couple exercises, you are going to very gently activate your muscles. Extension. First, turn with your back to a wall. Place a towel between your elbow and the wall. Set your shoulder blade down and back. Gently push back without provoking pain. Hold for 8 seconds. Do not hike up your shoulder towards your ear. External rotation. Turn so the wall is on your operative side. Place the towel between your arm and side. Set your shoulder blade down and back. Gently push outward without provoking pain. Hold for 8 seconds. Do not hike your shoulder up towards your ear. Internal rotation. Stand in a doorway and place the towel between your arm and your side. Set your shoulder blade down and back. Gently push inward without provoking pain. Hold for 8 seconds. Do not hike up your shoulder towards your ear.
Great. So as you can see, the key thing was about pain as the threshold to know when to stop. So as I said, the foundation for therapeutic exercises when it comes to injury begins with flexibility training. So the more flexible the muscle is, the more you are able to move in the range of to achieve the range of movement. And the more you deprive the joint of having that range of movement, the more stiff the joint becomes, the more stiff the muscles become, and therefore we have so many consequences. Now, the key thing regarding stretching is that we recommend static stretching and then PNF, that proprioceptive neuromuscular facilitation, whereby you gently stretch the muscle, and then there is an added contraction of the agonist or the antagonist. So that inhibits the stretch reflexes, and therefore inhibits the Golgi apparatus organs and helps in lengthening the muscle. The next thing is the strength training. So you achieve strength by subjecting the body to resistance, the muscle to resistance. And so by definition, exertion of muscular force against resistance, that you can use the body weight of machines, barbells, dumbbells to improve muscular strength and power, and then also endurance. Now, isometric exercises, we've mentioned, some of them have been shown in the video. It's more suited for the acute injury stage, and you do that 30 seconds twice daily for 2 to 4 weeks. Then isotonic exercises also take the joint through a specific range of movement against a fixed resistance. Isokinetic exercises can be done using specific machines, but if you don't have those machines, then it's not really, but you can stick to your isotonic and isometric exercises. Now, this is a knee strengthening exercise for rehab, another short video that's only less than a minute, and just want us to show this.
I'm going to show you some of my favorite knee exercises for rehab and training purposes. Try these progressions: split squats, tempo split squat, tempo foot elevated split squat, then add weight over time. Sliders, double leg eccentric, double leg, single leg eccentric, single leg. Side planks, short side plank, side plank hip abduction, heel raises, double leg, single leg, deficit single leg, then add weight over time. These exercises require minimal equipment and will increase the strength, range of motion, and overall resilience of your knees.
Beautiful. So what do we gain? How is the adaptation? What kind of adaptation when you subject the joint, the muscles around the joint into these resistance exercises? Now, the first thing adaptation you notice is the neural adaptation. So the number one, you increase the number of motor units recruited for action, which therefore increases the rate of force development. You increase the inhibition of the Golgi tendon organs, and therefore again increases the force production capacity and force efficiency. Then also there's inhibition of the antagonistic muscles, as well as the increased motor unit synchronization. So by subjecting the joint, the muscle to resistance, you build a stronger muscle, and that's the mechanism for increasing the strength. Now, the morphological adaptation, there is increased fat-free muscle mass, therefore increasing muscle strength, and also increased cross-sectional area by increasing the myofibril size and then myofilaments. That obviously increases the contractile capacity, force production, and capacity. Then also there's increase in type 2 myosin heavy chain. Type 2A are more suited for effective use of glucose for the muscle. So by subjecting the muscle to resistance, you increase the force production capacity. And then also there's an increase in angle of pronation and then reduction in mitochondrial volume density simply because of the size increase. So in the end, what happens is that you have an increased amount of contractile tissue attached to the tendon, and then there's the decreased oxidative capacity. However, saying that by subjecting the body to more repeat sets and repetitions, you eventually have an endurance capacity. We'll talk about that later on. So what are the metabolic adaptations? There's an increased store of ATP, increased creatine phosphate, and then increased storage of glycogen. So all these will lead to an improvement in the force production capacity and also increased glycolytic capacity by subjecting the muscle to resistance. Then what are the cardiovascular adaptations? There may be a reduction or no change in resting blood pressure, no change or a decrease in resting heart rate. And all these will lead to improved cardiovascular disease profile, reduce the work for the heart at rest, and increase cardiovascular endurance, functionality, and also reduce relative workload. So by repeating these exercises, you enhance your endurance capacity. So let's look at the endurance capacity exercises. These increase the aerobic and anaerobic muscular capacity. How do we do that? By adjusting the sets and reps and the resistance you use, and also the pace of the strength training activities. How do you increase, endurance exercises also increase the aerobic and anaerobic cardiovascular capacity. So through running, cycling, step-up machines, swimming, upper body, upper extremity cycle ergometer. So sometimes somebody might have hurt the ankle, he cannot really run, but you can use upper body ergometers, to exercise the upper body, and that enhances your endurance ability. You can use cross-country ski machines and elliptical training machines. So by doing these repetitions, you enhance your oxygen utilization capacity for production of energy. And that's when your oxygen utilization is enhanced as you keep doing these exercises. Proprioception, the next level is proprioception, where we are talking about the muscle sense and joint sense. So by doing these proprioceptive exercises, single leg stance for balance, using balance board. There's basic type, advanced and uniaxial and multi-axial types. Also, we have upper extremity proprioception, where you can do weight bearing on the hands, and then you can do weight bearing on the balance board, or that helps with your position sense. And this is the advanced stage of rehabilitation, where you are now getting ready to return to sport. Now, so when it comes to agility and skill, so this is where most of the range of motion has been achieved, as you saw in the chart I gave earlier. So it represents the advanced phase of rehabilitation, and it fine-tunes the athlete's rehab process towards resumption of sport. Then it also leads to a progress. It's a progress of progressive learning and relearning. Then it is progress from basic fundamentals drills to more complex activities. So all these things are cautiously done based on, you know, the level of pain, as has been highlighted earlier, and then you build it up until the person is able to come. These activities are very, very important. There was a Ghanaian player who was predicted to be the next Pele, and unfortunately, injuries prevented him from becoming, simply because there was no proper rehabilitation process, and as a result, he could not fulfill what was predicted. Now, what are the common pitfalls in rehabilitation? So using, some of these things have been highlighted by Dr. Abuna Tan already. You need it's teamwork, and you need, as physicians, we will make the recommendation, but you need somebody, a physical therapist, to supervise and ensure that these things are done properly. And even diagnosing, as he said, that most of the time you find somebody injured and he's gone to take an x-ray before he comes to show you the x-ray, and then you ask you what to do. Those are all bad practices. And there's a tendency to do too much too soon. And it's important for you to explain the principles to the athlete or the patient, so that they understand that it's a process. And as they cooperate, eventually they will come back to the sport at the expected time. So there's also the zeal to return to participation, which outweighs athletes' common sense and awareness of injury. So sometimes they don't really understand the severity of the problem. And some of them would want to use shortcuts and try to return. And in the end, they may completely be out of the game, maybe even permanently. And then also there's a lack of motivation following injury. So there can be mental health issues, you get depressed about the whole situation. And it's important for the person to stick to the rehabilitation program. Then there's also the misapplication of the concept of no pain, no gain, leading to the tendency to worsen injury. So, well, if the more pain I get, the better. But this whole rehabilitation process, the exercises involved must be guided by the absence of pain. So if there's any pain, as you saw in some of the videos, then you have to stop. Then there's also unreasonable expectation regarding the recovery from injury. They need to understand the principles. So that's me done, actually, very, very short presentation. And the emphasis is just based on the physiology, the adaptation, neuromuscular adaptations that makes the joint, the muscles better prepared for the stress of the normal life that they encounter. If a hamstring strains, for example, the hamstring strain will happen because the muscle is not ready for the demand that is put on the muscle. So when the muscle is not prepared for that, that's when the injury happens. So in building somebody back to routine activity and return to sport, it's important to build the muscles. The flexibility training and the strength training keeps the muscles and in the right state to endure all the stresses their sport in particular put the demands that it puts on them. So thank you very much for your attention, and I will be happy to answer any questions that may be asked concerning this. Thank you very much. Hello. Hello. Hello, can you hear me? I'll hand you over to Dr. Jordan Ketia, please.
Hello, good afternoon.
Good afternoon. Are we okay?
Please, did you hear me the first time? Was I online?
Say that again, sorry.
Yeah, hello, Ernest.
Hello, Prof.
Yes, you weren't clear. I mean, we couldn't hear you. So check your microphones well.
Okay.
All right, thank you.
Thank you very much, Prof, for drawing my attention. So thank you once again, Dr. Dalibo, for your presentation. We'll move on to our second presenter, who is going to take us to joint injuries in sports. And our second presenter will be in the person of Dr. Anthony Annan. Dr. Anthony Annan is a consultant physician in sports and exercise, as well as musculoskeletal medicine, and a general practitioner who obtained his MBCHB from the University of Ghana Medical School. He has other qualifications, which includes a master's degree in sports and exercise medicine from the Queen Mary, University of London in 2001. He's also a fellow of the Faculty of Sports and Exercise Medicine from the Royal College of Physicians, Dublin, and the Royal College of Surgeons in 2003. He also has membership of the Faculty of Sports and Exercise Medicine, Royal College of Physicians, London. Both of them were acquired in the year 2007. He's also a fellow of the College of Physicians and Surgeons, Faculty of Emergency Medicine in 2009. He's trained in ultrasound, musculoskeletal ultrasound from the University of Oxford and Bournemouth University, from where he acquired a postgraduate certificate in musculoskeletal ultrasound in 2015 in the University of Bournemouth. Dr. Anthony Annan is also a member of the General Practitioners of the UK and acquired this in 2018. He's also a fellow of the College of Sports Medicine, American College of Sports Medicine in 2018. He's a fellow of the Faculty of Medical Leadership and Management in 2022. He currently works as the lead practitioner and clinical lead, quality and governance manager in Access UK, a sports and exercise physician as well at the Specialist Hospital in Essex. He's a consultant in sports and exercise medicine and worked with the Spire Hospital in Essex between the year 2011 and 2015. Dr. Anthony Annan is a tutor and examiner with the London and Bath Medical School, Queen Mary, University of London, and he's a lecturer in sports medicine and rehab medicine, the Faculty of Family Medicine of the Ghana College of Physicians and Surgeons. So our next presenter is in the person of Dr. Anthony Annan, who is going to take us to joint injuries in sports. And we all identify that joint injuries is a major issue, either because of contact from other players, or it could be as a result of the exertion that some athletes engage in based on the reward system. So Dr. Anthony Annan, please, your audience, we are ready to listen to you. Please take note, you can put questions in the chat box awaiting the other two presenters. Thank you very much. Sorry, Dr. Anthony, please, we can't hear you. I think you are muted. Dr. Antonana, sorry,
yes,
you are
can
muted.
you hear me now?
Yeah.
Can you hear me?
Yeah.
You can hear me?
Yes.
Okay, all right. Can you see the slides as well? Sorry.
Now we can hear, but your slides are not
okay.
Seen currently.
Can you see the slides?
Yes, please.
Okay.
But it's not on slideshow.
All right, let me do that.
Kindly put them on slideshow. Thank you very much.
It's okay now?
Yes, please.
Thank you. Finally got there. Thank you all very much for inviting me to this session. I've heard some of the presentations. Unfortunately, I'm working at the same time, so I have to juggle between meetings and this presentation. But thank you all very much for inviting me. Now, this topic is so huge. I tried everything I could to minimize it one way or the other. And looking at what the other presenters have done, I think it's made my work easier. I'll skip the rehabilitation side of it because they are the experts in that field. Dr. Dadibo and Dr. Abina, and some of the people who are watching this I know as well. So thank you all very much. Now, what I intend to do with this slide, there are quite a lot of slides, but I'll skip through them. The reason for that is I'm looking at a group of physicians who will be family medicine physicians. I'm looking at physicians who will have interest in sports medicine. And I'm looking at physicians who actually do team sports. So I've combined all of that. So you will find as I go through it, there will be a common theme that will be coming up. So I will not need to repeat that, but it's important to just cast an eye on it. I think hopefully I'll share the slides eventually, so that you get the theme of what I'm trying to put across. Now, in the last few slides, what I will do is I will look at the changes that's coming up. Some of them are quite new, and some we all know already. So I'll share that, and then hopefully I would have given you the information that you will need, which we will all need actually in terms of our practice. So let's begin. Now, I mean, if you look at joint injuries, it cuts across so many areas. You need to look at the common injuries or joint injuries that you will probably come across, either in your office, on the page, on the treatment table, or review in your office. Depends on what kind of injury is. So I'll start with ankle sprains. Okay, so ankle sprains are common. I think they are more common than the rest, but you will come across the rest anyway. I'll be skipping through this so that I get a good idea of what you have to look at if you are a sports physician or a GP, general practitioner, or wherever, and you are sitting down in your office and somebody comes around with an ankle sprain. The management of it depends so much on that person's status. I mean, whether that person is an athlete or somebody who works in a bank, normal occupational status or not. But these are the things that you will come across. So it's quite common. And we all know that this happens when the foot gets twisted over, rolls, or turns beyond its normal range of movements. So in terms of the sprain, there are ligaments around the ankle, which is basically functional anatomy, which you have to remember. You don't need to know the attachments per se. If you know it, that's great. But if you don't know it, at least where the swellings and so on will be, it's quite easy to pick up if you have the functional anatomy in your mind. So this is what it is. I mean, you can see the ATFL, calcaneal, and the posterior ligaments. These three, but this is the most common, ATFL. But I'm not going to go deep into it because going through ATFL or these ligament injuries will take an hour or so to go through. So I'll just mention this briefly and then move on. So these are the ligaments I mentioned earlier. So you have this in your mind, you will be able to manage these kind of patients who come in with these injuries. Now, most of them who come in with ATFL ligament sprains, you see a swelling, which is very well delineated in front of the fibula. So you know straight away that this is ATFL. But again, this is for you to put in your mind as we go along. The symptoms are quite straightforward. So we know you'll get pain, swelling, bruising, and instability is much worse. especially if it borders on chronicity. The treatment options, I mean, it's all been mentioned, I think. So I don't want to go into it in great details, but always when you're examining these kind of patients, have surgical interventions in your mind. If your treatment, rehab, physiotherapy fails, remember to have the option of surgical review in your mind as well. So this has been mentioned. I'm glad Dr. Dadibo and Dr. Adna mentioned all these things. So I'm not going to go into this. I've picked these up because what I do in my work is I go in with a rehab team to look at how they do things. And I pick some bits and pieces from there. Preventive strategies, I'm not going to go deeply into it, but this is the basic principle. You have evidence-based strategies, including warm-up, stretching, strength conditioning, and don't forget education on how to deal with proper technique and biomechanics. And obviously, we have these things are resource intensive. So you need equipment modification as well. The knee, we all have this in our minds, isn't it? I mean, we have these ligaments, which I don't want to go into it, but this is just to give you an idea of what to expect. So I always say to team physicians and the ones I've worked with, carry a small book. There are very good small books with you when you are covering sports. And those ones who have propensity of injuries, you will pick them out in your pre-assessment of these players before the season starts. Having this is very good. It gives you a good idea of what to expect. We know that the common areas of injury in the knee is the ACL. We know that bilateral collateral ligaments and the meniscal tears. All these have tests, clinical tests, which you can do to pick these things up clinically. So have a clinical judgment based on what you've seen before you request imaging. It's very important. I will be saying this as I go along. But if you want to go into sports medicine or into team sports, you'll be hounded by, Dr. Dadibo said it, you'll be hounded by the insurance companies, by the coach, by the athlete, by the families, you see. So have this thing in your mind. Judgment, history, don't throw away history all of a sudden. History, physical examination, have your own clinical judgment first, and then decide on the imaging to do. Now, if you get the imaging, don't treat the images, treat the patient. So you've got a patient in front of you, don't just go on the report from a radiologist, because the radiologist hasn't seen the patient. So he doesn't know what he'll be talking about. But if you give him the information that he needs, he will help you with it. Supposing you don't know that it's MCL, you don't know about MCL, you can just tell him, look, there's a swelling in the medial part of the knee. I'm not quite sure what it is. I've done all the tests for MCL, it's negative. But I still suspect there might be something there. That will help him. If you don't know, just say you don't know. I've done it many times. Just tell them you don't know. You'll get a better report, which gives you a better outlook on how to see such patients and treat such patients. And again, I think Dr. Dadibo said it, teamwork is a key thing. Don't forget that. Teamwork is one of the key things that will help you if you are in the group of family physicians who will sit in your office and see sports patients, or people who work on the pitch side with teams, and people who will work with them post-injury as well. So remember that. Don't throw away the influence of the old-fashioned important history physical examination. Remember that all the time. Now with the knee, we have these syndromes, which again, you have to bear in mind, patellofemoral pain syndromes, they come around from time to time if you're looking at after team sports of athletes who play team sports. Patellar tendonitis, you have to remember that, and knee sprains and strains. These will come up and you are examining, you are not getting anything, but the player is saying, look, it's still painful, I can't walk. MRI has come back negative. The player is still complaining. This is where you find yourself in that middle ground. What will help you is to take history, physical examination, and then examine and then coordinate with the player or the patient, okay, so that they know the pathway of the management. And don't forget, get other people in. Teamwork is very important. You go to physiotherapists, you will get a rehab specialists, you will get the sports scientists. They are all there. Put your heads together. Look at what can happen before you send these patients out for imaging or for someone else to have a look. Now, you learn a lot that way because these team players, they don't normally fit the textbooks you read. You see, you come across areas where you'll be in limbo. Let me repeat, you will get better understanding if you get other people involved to discuss the case, and then you move on from there. So that's very important. Now, this is one of the, this is basically patellofemoral syndrome, but this is caused by chondromalacia, which, as you can see, this roughing part of it. I'm not going too deep into that. I've put this there just to remind you. Again, this is patellar tendonitis. Now, the signs and symptoms, you can easily bring it out from the diagrams I've just shown you. They actually Google photos, so you can decide on where you examine these patients, and then taking the management forward. But accurate diagnosis, again, I can't stress this hard enough, because if you are in team sports, you see, that's the thing, there are too many people around you. So when an injury happens, your focus then all goes straight to the injured part. Avoid that mistake. Always take a quick history. You see, it doesn't matter how many people are, talk to the person, to the player, take a quick history. If you know the player's history from the pre-examination or history taking before the season started, it will help, yes. But remember, the diagnosis is not imaging. Diagnosis is always the old-fashioned medical history, physical examination. Don't lose that, that part of your training or our training. So it's important that you don't skew yourself into imaging before you assess the player. Yes, imaging will help. It will help guide you in terms of what to do. Again, I've just put this in. Remember, surgical intervention. These are the themes I want you to remember. That you are treating somebody, you have price, you have to put that down, medication, when to give it. You've got physical therapy, you've got rehab in your mind. Think about bracing and supporting the devices. These are all things that should be in your mind. Now, I've put this there because sometimes you don't get the support you want from the physiotherapist. He or she may be elsewhere. So you need to have these things in your mind, so that when you are discussing the injury with the physiotherapist or rehab doctor, you have good understanding amongst yourselves of what to do before any surgical intervention comes into the mix. Okay, I'll skip that. Now, in terms of shoulder, again, shoulder injuries are fairly common. I mean, if you cover team sports, basketball, cricket, and so on. But football, you get it. Rugby, you get it, you know. And have these things in your mind, that shoulder injuries are there and it can affect athletes in terms of what they do most. And the common ones are obviously rotator cuff tears, which you have. Now, one of the things that happens with rotator cuff tears is sometimes you go to the player on the pitch, you go to a player on the pitch, and then you ask the question, what is wrong with your shoulder? He will just be holding it. Well, I've got pain, doc, I've got pain, shoulder. So it's very vague. You see, very, very vague. Now, still, you can find out what happened. He will probably say no in the heat of the moment. He will probably say, I don't know. I mean, sometimes you see it, sometimes you don't. If you're on the pitch, things go on very fast. On TV, slower. If you watch the game on TV, slower. But if you're on the pitch, things are so quick. People are distracting you. People are crossing in the front, and so on and so forth. So sometimes you will miss the injury, So you really depend on the player to tell you what it is that has happened. That is on the pitch. Then you decide, look, the player has to come out. Obviously, there are pathways for that. You and the physio will do that. We'll mention that to your coach and so on. So you take the player to table, then treatment table. Then you can ask more questions. Now, but you are needed at the front. So you go back to the front to cover the rest of the game. So in between this, you might lose some of the information you get. It's very strange, but this is what happens. So you have to bear that in mind if you are a family physician who wants to go to sports, team sports. So you will then have that issue of losing some information. But I'll come back to that close to the end. I'll have to run through this very quickly. Rotator cuff, we all understand what the symptoms and signs are. So I'm not going to go through that. I'll send the slides anyway, so go through that. Now I've put this in just to give you a good idea of where the rotator cuffs are and then why they get injured. So these are just a memory kind of case memoir for you to remember, which I'm sure we all do. If there's a tear, sometimes you come across players who do this. Exactly like this. You put your hands on their shoulder. This is where I've got a pain, doc. Remember that a lot of these players are very poor historians. They don't give you much information, because one of the reasons is once they have an injury, they are thinking about their contract. It's very important because they know that to take them off playing the first team, and they will struggle through rehab to come back. And rehab takes a while. It's not a quick fix. So if you have a manager, the manager will push you to the limit. When can a player come back? When can a player come back? It's one of the things that will be put on you in terms of pressure. I've had a chairman coming to me before saying things like this, And I said, well, what do you want a player next week? Then ask the player, and he started laughing. So sometimes you have to use your own technique to get them to understand that medicine is no magic. It's something that you have to go through, and they have to be patient for that, including the player, because the player is thinking, I'll be out for 4 weeks, I'll be out for 6 weeks. It will affect my chances, Go through that process with the player, talk to him. They will understand that it's not all doom and gloom, and they will come back, certainly come back playing. Now, again, I'll have to repeat this. Again, you are treating the player, not the scans. If you've got a means of getting the scans done, fine. If you don't, depend strongly on your clinical judgment. And clinical judgment is something that you've been trained to do. So use it. I've always said this. If you make a mistake, so what? You will learn from it. You will learn from it. And that is how we all learn. You cannot go through situations like this without learning. We are all learning all the time. And some of these cases in players or athletes that come up, if you have a book, which you have to have if you are in team sports, put that down somewhere, read it, look at where you've gone wrong, correct it, and then work hard on making sure it doesn't happen again. That is where you then look at other options of CPD trainings and things like that to help you to build up your knowledge for the future. So these are things that you have to remember. So don't worry too much about MRIs, ultrasounds, or X-rays. If you have them, it helps you, no question about that. But please make your own diagnosis. No two physicians who give you the same diagnosis. They might have the same thinking, but the diagnosis eventually will come up. So try and do that, and then involve other colleagues of yours. Let somebody else cast an eye on it, or even you can call them and then say, look, this is the situation. Any ideas? Keep doing that. Teamwork all the time. And then don't focus your mind too much on ultrasounds and X-rays. Now, treatment options are always the same. We've talked about rest, we've talked about physical therapy, rehabilitation, anti-inflammatory medications, steroid injections. If these things fail, surgical repair. These are the themes I want you to remember and keep at it. Now, dislocations, I'm not going to go into that, but the only thing I will say to you is this. Now, if you have a player who comes to you with a history of epilepsy, then you have to remember that this player will be at risk of shoulder dislocations. There was one I came across, and actually he's had posterior dislocations many times, but he was a defender. He was a defender, a very good defender. And are you going to take him off? Are you not going to take him on? So that was a question that I was given when this player came to be signed up. And I said, look, this player has been rehabbed well. It won't exclude a future posterior dislocation. Epileptics, they tend to get that. So because I know this about a player, anytime a player jumps or falls, then I stand up. Because I want to see whether he's holding the opposite hand, which will obviously give me a good idea that there's probably some dislocation going along. And he said to me he told me in the face, I know this job better than you, doctor. I've been relocating it with ease, and I said, oh, then you better do my job. I mean, these are things which will help you kind of get that kind of synchrony with players, you see. So it's so important to remember. Now, on the pitch, if there is a dislocation, I'm only saying I've done two. Now, a player on the floor who's holding a hand, you see it, and then the physio is saying, what do we do? Do we relocate it now, or do we take the player back to A&E to get X-ray and then to be relocated there? According to a lot of this literature, you do it there and then. You see, you do it there and then. So I had to relocate it there and then with a towel, which was put around the shoulder joints. Now, the reason for that is the longer it takes, the more difficult you have this relocated. Now, the more difficult it is, then you are risking heart disease and other small tiny bones that will be flipping around in the joint. Then it becomes more difficult to relocate. And then you are thinking about the surgical reviews and intervention, which will further delay the player's return to play. Now, one of the things with dislocation is this. In my notes, I've done that many times from orthopedics. Now, before you relocate on the page, you do this very quickly. On the page, you check for numbness or tingling. You know, that's a nerve that goes round the head of the humerus. Check for that. That was very quick. You do that very quickly. You make a note of it in your mind. Then you relocate, and then you do it again to check that. Movements, neurovascular deficits, look for that. And then you keep that in your mind, and then you put it in your notes once you get back to the treatment room. Right, again, I mean, these kind of players are usually resist the straight away sending them to the emergency room. Once you've reduced the dislocation, you can decide that, okay, you will need x-ray. The patient is, this player is not going to die. You've checked the neurovascular bundles. You are happy with it. You are happy with it. So go ahead and then book an x-ray. You can do that. Most players will have insurance. In Ghana, it's difficult. So you have to weigh that in your mind. You have to look at that possibility of getting the imaging, which is a fair point to say. You have to have that. But at least the player is safe. At least the player's hand is safe. Then you can decide that, look, this is what I want to do. And then you go ahead and do it. When the x-ray is okay, usually I follow it up with MRI. I usually combine the two, but there's pros and cons of either side, whether you want to do it both or not. Because I have, luckily I have the easier options here, but in Ghana, depend more on your clinical judgment. It's very important. If you have access to it, you can arrange for that to be done during the week after the game. Okay, so obviously surgical intervention will only be important when these soldier dislocations is recurrent. I'm not going to go too much into that. Now let's go into the elbow injuries. Now, elbow injuries, the ones I've seen more commonly, I've not seen a dislocated elbow on the pitch or in team sports for so long. I've still not seen that. Highly unlikely you will see that, but keep that in mind. The only time I've seen elbow dislocation is in the emergency room where I had to reduce. But on the pitch is highly unlikely, but keep in your mind that this can happen. But what you are more likely to see is the overuse injuries, which you all probably know. Lateral epicondylitis, which we all know to be tennis elbow. There is something that you come across from time to time. I'm not going to go through it too much because of I'm conscious of time, so I have to be very quick on that. That is this is what you have to bear in mind. Golfers is in the media aspect of it, so remember that. The pain and tenderness is similar to the tennis elbow, but on the opposite ends. Best way to treat is to do absolutely nothing. But this is for physicians who are in their offices and are seeing people who have it, bankers and so on. Give them time for this to recover. Not to athletes. Athletes, you have to do something about it, you know, and one of the things you have to think about is rehab. I always offer them that first before looking at the possibility of corticosteroid injections and then rehab exercises after that. Wrist injuries, I'll run through that very quickly because of lack of time. There's the scaphoid lunate ligament tears, and then you have the TFCC tears, which I'll mention very briefly. That is the scaphoid lunate gap, which you know. If it gets wide, for instance, that's what you get. Very important. You see it on X-ray. That is what it is. And then you have the ring sign. as well to look out for. If you don't see the ring sign, it doesn't matter. This is very important. Okay. Now, a player will come to you holding the hand like that. Anytime I see that, the way it looks like it on the diagram, on the diagram I've shown you, actually, I'm thinking TFCC. It can be anything else, but that's what I'm thinking. So if I have to refer, I have to put that in as my differential. So it's quite important. You find that in tennis and then sometimes in other team sports. Okay, these are all similar themes to what I've mentioned earlier. When it comes to the hip, remember the labral tears. Okay, that's one of the things you have to bear in mind. It's very important. Don't miss it, because sometimes you do an X-ray, don't find it. Sometimes you do MRI, don't find it. You have to repeat it, and with your own clinical judgment, send it to orthopedics. They will probably do a different kind of MRI contrast and possibly do arthroscopy in that area to correct that. Now, that causes labral tears would then cause impingement, which is this is a tear, for instance. It causes impingement. There are different kinds of impingement, which I'm not going to go deeply into it. This is purely for academic use. If you are in team sports, you have to remember that as well. It helps you, basically. Again, the diagnosis and treatment is similar to what I said earlier. Now, spine injuries will be rare for you to see if you are in team sports. You see them more if you are in family medicine in your office. A lot of patients come in with back pain. You do MRI, and then you pick up the spondylosis, spondylolisthesis, and then pass into articularis. Again, this is there for functional anatomy for you to hopefully remember. Treatment is very important. You have to involve teamwork, physical therapy, pain management, and obviously the pain management team who do epidural injections, or somebody who has expertise in that area, and then rehab the player or the patients. Surgery will be an option if nothing works. Okay. Okay. So how many minutes do I have? Do I have 10 minutes or?
Hello, Dr. Anand, please, you have 5 more minutes.
5 more minutes, okay.
Yes, please. Thank you very much.
Okay, now I'll run through this then. Now, evidence-based medicine, we all know it. We all know what evidence-based medicine. I'm not going to go through that. But one of the things we always forget is the fact that evidence-based medicine, yes, it's got these 3 components, available evidence, you've got the clinical expertise, but you have to remember patient values and preferences and your own clinical experience. Don't throw your clinical experience and patient values away and separate that from evidence-based medicine. It's very important to put all that together. That is what will make a better evidence-based practice for you to use on patient care. And obviously, you emphasize the need for scientific research, which is very important. The higher the quality studies, the better. But don't exclude other lower level quality studies as well. Even a blog has been noted to help, and case studies. So you have to remember, yes, there are hierarchies of it, but don't easily dismiss the lower quality studies from that. Now, I've emphasized this already, so I'll bring it up again. Don't forget patient history. And then you don't exclude x-rays. If you have to, please do it. If you don't have access to them, depend on your physical examination and your own clinical skills and judgments. Now, this has just come up quite recently, actually. This was published in 2012, but this is a new thinking that's come up. Instead of price Now they've inserted OL and they've now made it police. Now, this was actually presented at the American College of Sports Medicine a few years ago. The reasoning for putting this in is that they don't want people to, players and other people to have the idea of complete rest. It becomes too conservative and it affects the benefits of early tissue loading through exercise. I'm not saying suddenly go and then exercise. No, what I'm saying is do some minimal physical activity so that this optimal loading will help benefit early tissue repair. So there's a huge paper on it and there are graphs on it, very interesting. So now, instead of price, now it's called police. Okay, so you have to remember this. This is a new thinking that's come up. Actually, it was published in 2012. There are other literature reviews on that, but it depends on how you say it. But the thinking is that you have to optimize loading, which is part of the treatment for that. And do no harm is to avoid heat, alcohol, all of a sudden doing moderate activities, and then massage. What I referred to earlier is simple physical activity, not moderate activity that can cause damage. So you have to bear that in mind. There are other ways of managing joint injuries, manual treatments, which I've just put on there. There are a lot of literature on that. We've got taping. If you want to, as a clinician, if you want to train in that, that would be very useful. You've got electrophysical agents, which we all know most physiotherapists use. And then we've got the electrocorporeal shockwave therapy. It is resource intensive. You have to get someone to buy it for you to use, but they're all there. Now, teamwork is a key to this. Okay, collaborative care is important regardless of how you look at the player or athletes or anything in sports. It's very important. Look at the possibility of injections. They are used in hamstrings, they are used in joints, and but the outcome is not great. It's mixed. So don't keep giving corticosteroid injections. I do it 3 per year in the same joint per year, no more. After that, you have to see the orthopedic surgeon because what I'm afraid of is damaging the articular cartilage. Okay, so there's the option of this platelet-rich plasma, which is there. But again, if you look at the literature, there are mixed results. So it's not that straightforward. Anti-inflammatories, we've talked about it during my lectures before. Don't give it just to prevent future exercise soreness. It's not the right thing to do. It's been evidenced. So remember that. Give it only when it's needed. We've got ultrasound, which is there. You can either use ultrasound guided or landmark guided injections. I use both. Outcome is similar. So you have to remember, and I've said earlier that I give 3 injections in a year and no more. Now, ultrasound is a future stethoscope, okay? Eventually, it will be like stethoscope. Every clinician will have it, but it depends on how it's being produced. It's being slowly produced so that people can afford it. Currently, it's not easily affordable. Okay, the final bit I'll put up is my own experiences. I hope I've got 1 or 2 minutes. Now, if you are treating sports team players or you are in team sports, these are the things you have to remember. It's easy for you to throw away your history and clinical examination. I've been mentioning it, I'll keep mentioning it because I've seen somebody who ends up in court because of this simple thing which was ignored. Now, the mindset of treating such players are in 3 phases. Your pitch side treatments, which is very quick, but you have to have order in your mind. You have the treatment table, Downside of it is you have so many players after the team, they are coming around shouting, it disrupts your thinking. But keep that in mind. Then the quiet, silent office setting, which will help you to consider repeat reviews of such patients. Insurance companies will influence your thinking. Stick to your clinical judgments. Stick to it. And make sure that whatever the insurance companies want, yes, you do it, but hold on to your clinical judgment. It's very important. Bear in mind that players have poor historians, most of them are. And then you don't let imaging define your management, okay? Teamwork is very important. I've said that many times. Dr. Dadibo has said that. So it's very important that we do that. And discuss a return to play with your colleagues. Rehab medicine, physiotherapists, sports scientists, get them involved. One thing which I've realized and I keep seeing is you have to be ready for surprises, whether you are in a district playing, covering football teams or whatever, you have to always be ready for surprises and factors that can lead to chronicity in terms of joint injuries. Okay, so these are things that I've put together to make sure that you all remember that team sports is not about the individual. Yes, joint injuries impacts athletes at all levels. Literature review is important. Look at them. Don't treat literature reviews. It's somebody's work who hasn't seen your patient. Use that to guide you to help you to manage the patient. Very, very important. And obviously, we need further research on that. These things are emerging all the time. They're emerging. Things are changing all the time. Very soon, believe it or not, all of you will have ultrasound, which will be stethoscopes. It's coming. It's coming. Thank you very much. Thank you all very much.
Thank you very much, Dr. Annan, for your presentation and sticking within the time allotted. I would like to go ahead with our third presentation, after which we will take questions. Kindly take note that the chat box is still open for questions that will be put in the text, and much later would allow participants who would like to speak to unmute after the third presentation. So the third presentation is about head injuries in sports, head injuries in sports. Thank you once again, Dr. Allen. So we'll go ahead. Our presenter for the third presentation is Dr. Conrad Buckle. Dr. Conrad Buckle is a consultant in emergency medicine with the Northwest Anglia NHS Foundation Trust in the UK. He is an emergency clinician and a founding fellow of the Faculty of Emergency Medicine with the Ghana College of Physicians and Surgeons. He was a member of the original Ghana Sports and Exercise Medicine Working Committee, which developed the Sports and Exercise Medicine curriculum, and currently one of the faculty for Emergency Medicine section. Dr. Conrad Buckle also currently works as an external faculty member for the Kolebu Teaching Hospital Emergency Medicine Residency Training Program. He is also the chair of the Education Committee of the Ghana Doctors and Dentists Association of the UK. So without much ado, Dr. Buckle, please, your audience are waiting. And kindly note, you can please share your questions in the chat box. And after Dr. Buckle is done with his presentation, we can go into our discussion. Thank you very much. Dr. Buckle.
Thank you very much for that. Can you hear me or
yes,
and see my slide?
Yes, please. We can hear you. Okay. Only your slides are not on. Yes, now it's now on slideshow. Thank you.
Okay, thank you very much. Good afternoon, all, and thank you very much for joining us this afternoon. I thank the Ghana College and Sports and Exercise Medicine faculty for inviting me. I'm finishing off. It looks like the end of the day, so I will try my very best to keep within time. And it's fortunate. One advantage is obviously that some of the issues have been addressed or mentioned in some way by my previous speakers. So I'll be presenting on head injuries in sports today. As from my bio, which you just heard, I'm a consultant in emergency medicine. I've also had personal experience playing multiple sports and multiple injuries. I had an Achilles tendon injury last year, and I'm still recovering from it. So I hope to give you a broad awareness and understanding of the prevention of head injuries in sports. Prevention is always better than cure. A recognition of the head injuries in sports, some of the diagnostic and assessment tools, the effective management of head injuries with the prioritization of the athlete's safety, and then overall the importance of evidence-based guidance to be enforced by all the organizations involved in managing and hosting sports events. Just to look at some of the general flow of what I'll be talking about, I'll be giving a general overview of the topic, head injuries in sports. Concussion is the buzzword over the last few years, and there's been so much happening in that space. So I'll speak on that. We mustn't forget that obviously concussion meaning, and often the minor side of it, doesn't mean that there aren't serious and often and sometimes life-threatening injuries to the head and neck region. So we must always remember that. Prevention and risk management or mitigation is also to be made note of. There are some advances in interesting research in the field, so I'll touch briefly on that. In my area, the emergency management of acute head injuries, that I think a lot of you will be familiar with the basics, so we won't spend too much except a reminder. I'll just give a couple of clinical scenarios, and then I've already sent two very key references. If you look in the chat, you'll see a link to a major incident triage tool, and then another one to a recent May 2023 head injury assessment and management guidance from the National Health Service in the UK. So again, the benefit of coming at the end is I've had a chance to listen to some of my previous speakers, and many sports which are people engage in from amateur to professional have risk of injuries, and in some more than others, head injuries are a particular feature for which precautions should be taken. From earlier today, we learned of pre-participation assessment, nutrition in sports, rehabilitation in sports, and these are all important with respect to head injuries. For example, previous history of head injuries or concussions are important in your pre-participation assessment. Adequate nutrition and hydration is obviously important in the peri-event stage, because of it, dehydration can make the effects of a head injury worse, and nutrition post-injury, good nutrition will improve rehabilitation. And the rehabilitation itself, there is a specific neuro-rehabilitation which has to be undertaken for head injuries. What you see, they're highlighted in yellow, are from American Association of Neurosurgeons, just an overview of some estimates of the numbers of head injuries for different sports. Football, and here we're talking American football, not soccer. Soccer is down on, I think, the 5th or 6th, which is 26,000, 64,000 for cycling. So this gives just an overview of some of the sports. Specific to Ghana, obviously, we've got cyclists. There's a basketball, a burgeoning national basketball league. Obviously, football, as we know it, or soccer to the US. Playground equipment, we don't have that much because we don't have organized areas for children. But yeah, exercise equipment causes also quite a lot of injuries. In children specifically, these are some of the sports causing injuries. You know, baseball, cycling, basketball, skateboards. A lot of these are not relevant to our environment, but if you can think of any of the common games that children play and what they get up to, climbing trees, or actually for some of the team sports, some of our playing fields are made of surfaces. Basketball, for example. The surfaces, the asphalt surfaces, are quite non-giving and probably make people more prone to significant head injuries. Now, some of the mechanisms of injury, I'm sure you can all guess or you're aware. So direct collision in some sports. Obviously, if you play a sport where, you have tennis, for example, where two people are on opposite sides, the likelihood of them clashing heads is virtually zero. But in a team sport such as basketball, hockey, handball, you can have direct collision of heads. You have acceleration deceleration forces of rotation or extension, flexion, whiplash type injuries. There are sports where you have objects which are thrown. So you can have an object thrown or which is hit and then impacts with the head, such as baseball, softball, or indeed in football, as we know it, a hard shot, can hit the head. People can fall directly onto the head, and you have blunt injury versus penetrating injury. And whilst penetrating injury can be quite dramatic, the issue of concussion, which has come to the fore in recent years, highlights the fact that just because you cannot see an obvious injury to the outside, no big bump, no bleeding, doesn't mean that somebody hasn't suffered significant brain injury. Injuries may be single and isolated, or they may be repeated and chronic. And again, a lot of sports where there's high impact, football where people are heading the ball, American football where they are wearing helmets but still, hitting each other, has brought to light the fact that chronic, repeated, minor to significant, trauma to the head can cause long-term effects. And we should always remember, just to end here, that spinal injury, so impacting on the head, has forces which transmit down the whole of the spine, and there may be other significant trauma other than the head. So again, one of the previous speakers, Dr. Tanner, mentioned about the fact that you should not take your eye off the field or off the players, because it is very important to have some idea of how the injury occurred. It makes a huge difference. So we're all familiar with boxing. That's one of the examples of the high risk sports. This is a collage. So the top left, American football. Whilst you're looking at these images, I will make mention of it, but take particular note of some of their protective gear. So with the American football, they've got padding on their heads. They've got the helmets. In recent years, they have back protectors which protect their spines, which extend up to the neck, so that it again offers more protection to the cervical spine. At the bottom left, we're familiar with football, so this player on the ground is, he could have hit his head directly on the ground. He could be kicked in the head. The ball may hit him in the head directly. At the bottom right, we've got a horse, equine sports, and a horse weighs several thousands of pounds, and any fall from height or injury from the horse's hoofs can be significant. Then top right is rugby. Here again, we've got basketball. Even though one might not think of, but it's a game played at pace. You've got very tall, very big guys, and coming down from heights. Sometimes they get somersaulted, overturned. You have wrestling, the top left. You have skiing, cycling, road cycling, and ice hockey. Now, an interesting one from Spain, bullfighting. There are the obvious possible causes. A big, very heavy bull, angry at that, and no protective gear of any note for the matador. Cricket, and the bottom left is interesting to note as well as the top, because both of them, baseball and golf, are spectator sports where quite often spectators are close or can be close to the field. So a spectator that's not paying attention can easily get hit by a high velocity baseball or golf ball. So, the field medical team is, whilst the attention is to be paid to the players on the field, there must be other provision made at the event site for spectators being injured with this. Now, in ice hockey, they have, as the bottom right, they have large, very high plastic, high impact plastic protective shields around the rink, so that the pucks which travel at very, very high speeds, have reduced chance of going into the crowd. Here again, we've got Formula One racing, NASCAR racing, skateboarding, and these are some of the protective items. There are multiple, protective equipment for different sports. In the center is a hockey goalkeeper. That goalkeeper has to face, hard pucks traveling, at very, very high speeds. And so he has just enough space to see out of the, from the mask. Pretty much all of the face is covered and the sides. And they often have a flap also, which goes down to protect the neck. If you look on the top left, that's a cycling helmet. There's a mouth guard, the bottom left, goggles for eye protection, and headgear for boxing. Now, a few years ago, some of you may or may not have watched the movie, and you know the true story. Many years ago, a doctor took, a lot of interest and a lot of effort to investigate, concussion and chronic traumatic brain injury, which has now impacted globally and internationally into evidence-based regulations for any and all sports where there may be the possibility of head injury or concussion. This is pediatric concussion. So in latter years, in the last few years, concern has also been raised, having determined that adults have long-term brain injury. Then the question obviously to be asked was, how much contact and how should the sports that children play be monitored, adapted, or the rules changed so that their growing brains do not suffer long-term impact. Now, the history of the head injuries can be classed as traumatic or non-traumatic as a general, basically, and the incidence of the head injuries in different sports varies based on whether it's two individuals playing, whether it's a team sport. Some sports are played at a faster pace than others. Some use the object which is used in the sport, whether it's a ball, whether it's a puck or a golf ball, how hard they are is important. And the risk factors include the size of the individuals concerned, whether part of the sport includes direct contact with the head. So in American football, for example, rugby, boxing, it is part of the sport to have some contact or purposeful contact with the head as part of the sport. Now, with rugby, American football, tackling with the shoulders and head, impacts. Whilst the head may not be hitting another head, you've got very large, heavy sportsmen, or sports sportsmen and women who are impacting the head and neck with somebody moving at speed, 5-10 miles an hour or more. Now, the impact of head injuries on athletes and organizations. Obviously, there's the impact on the athlete themselves, their families, if they have significant head injuries and are disabled as a result of those injuries. The organizations, increasingly, I think one of my colleagues earlier mentioned about doctors losing their jobs and being sued. So organizations are now being held accountable, and so there's been a flurry and an increase of international updates in guidance for management of head injuries and concussions, and pretty much any major international sports organization, the IAAF, the FIFA, they will all have evidence-based, and because it's evidence-based, there is similarity and agreement and consensus across most of them. And in the Premier League football here in the United Kingdom, the different leagues in Europe, South America, Ghana, other parts of Africa, there's consensus agreement on the fact that concussion needs to be taken seriously, and there has to be focused and guided advice on when people are able to return or should return to active play. Now, the evaluation and management of concussion, I think most will be familiar with the signs of a significant head injury, either immediate unconsciousness, seizure, loss of sensation, movement, severe headache. Now, the pathophysiology, again, most of you will be familiar with the fact that the brain sits in a hard skull, and any rapid movement or contact with it will either directly damage the brain at the point or at the opposite in a contracoup injury. And then there's still a lot still being discovered about the brain, but its recovery, everybody is different in the recovery, and determining the level of injury, even with all the modern available imaging and diagnostic tools, can be difficult. But basically, because often swelling is part of, and bleeding within the cranium is part of the pathology. Increasing pressure leads to some of the well-known signs of major traumatic brain injury. Now, with regards to mild or moderate concussion, symptoms and signs related to behavior, difficulty performing tasks, difficulty with memory, these become sometimes more subtle. And some of the sidelines assessment tools and protocols, such as the sports concussion assessment tool, which has gone through a number of editions. I think it's on 5 now. So they allow a standardized way of asking certain questions, and then by documenting the answers, having an objective assessment of the player or the sports person's reaction. Now, some of these tools are used in the pre-participation assessment, so that in the hours or days afterwards, a team doctor or sports medicine physician can look back and then compare current response or scores of the tools to the patient's current state. Diagnostic imaging. X-rays used to be, as head or skull X-rays, but now CT scans, MRI scans, and other variants of imaging, depending on the ability and resources, are available. And quite often it's a question of serial imaging comparing the first images to subsequent ones. And in the case of those who have had chronic trauma or previous concussions, then comparison of any new episodes of injury and looking at trends of changes is very important in determining the prognosis of these individuals. I mentioned about return to play guidelines, and I'll show a couple of images of some of the news headlines on the long-term implications now. The long-term implications are related to chronic traumatic brain injury, and there continue to be professional athletes and sports individuals, and particularly football, which have in recent times died. Some of them having had dementia so bad that even though they're in their 60s, they had no awareness of some of the foot, how famous they were or what they did as footballers. So this is one in 2020, and ex-football players can be more than 3 times at risk of dementia than other sports. Now, some of the other head injuries in sports, I did mention that we mustn't forget. I think Dr. Anand said just before, as the speaker before me, that you must not be distracted as a sideline, doctor or health professional, from the fact that you have to go through your ABC assessment of the patient. Obviously, if you're watching, you have some idea of what preceded the injury. You can get more information from some of the players who may be around, but you've got to assess the airway, the breathing, the circulation, any disability, and anything to do with the extremities. And don't forget, perhaps at the beginning, to add a C for any catastrophic hemorrhage or potential limb-threatening injury, which should be addressed with the aid of your team, so that they don't die from a simple thing like compression over bleeding vessel or straightening and splinting and obviously deformed limb, which may be lost if it is not addressed sooner than later. So some of the life-threatening and major injuries are skull fractures, and with that you can have, usually it's blunt injuries, but there are, if you watch any athletic meet, you'll see that the field events have a lot of safety issues around them. If you imagine a discus or a javelin, there have been major changes in them, including changing the weight of the javelin, for example, so that because people were throwing them almost 100 meters and over. And then obviously the nets around things like the discus and the hammer throw. But it is possible, to have penetrating skull injuries. So that those should be looked out for. Diffuse axonal injuries can be difficult to determine, and so scans, MRI scans or similar variants of it, and serial imaging can help determine changes in one part of the brain than another, and matched with some of the assessment tools, neuropsychological assessment tools. Cervical spine injuries, that's obvious. You've got ordinary plain X-rays can diagnose, barn door injuries, and then CT scans and MRI scans also. Facial injuries and maxillofacial trauma. These can be very, very scary, on site at scene. And the major thing is the airway and breathing, which will need to be secured as soon as possible, and provision made for transport one of the key things is using whatever adjuncts are available. And if the patient is conscious and the injury is isolated, they themselves will position in a way where any blood draining will not cause obstruction and will drain. So, but obviously in an unconscious patient, um, the sideline team will have to secure the airway and provide breathing support. At the right is just a reminder that the Advanced Trauma Life Support is an internationally recognized course. There are some other courses similarly designed to provide all people attending any trauma of any sort with a structured ABCDE approach, and then a primary, secondary survey, and resuscitation, along with promoting a team-based way of managing and treating patients and communicating with different specialties. Now, I've got a prevention. So prevention is always better than cure. I showed some examples, and some of the pictures of the sports earlier showed some of the equipment which was shown. Now there continues to be, so if you look on the bottom left, you've got a baseball player here. A couple of decades ago, the baseball helmet consisted of just the helmet part. If you look close enough, or you're familiar with baseball, you'll see that for some years there's now an extension of the hard protection over the ear, and there are newer baseball helmets which basically follow the whole of the side of the face, covering the jaw to prevent mandibular or jaw fractures or fractures of the maxilla. So that's part of the evolution. If you look at the catcher and the umpire, so you have an official who's also well protected. They've got a chest pad, they've got the head mask, and then at the top left is sideline treatment, a player getting, I think, massage of a cramp or similar, and that so the prevention of any significant head injuries. Now, head injuries under the ABCD's approach to assessment is the D. So it comes after airway, breathing, and circulation. So that is the priority. And if you can minimize that, you minimize the effect or the lateral effect, adverse effect of the brain injury. The top right is a very important role, which is the referees, those who administer and enforce the rules of the sports. As the sports have, specified and improved on equipment, changed the rules to minimize potential head injury causing contact, etc. It is up to the officials, the referees, whether it's baseball, rugby, football, they have to enforce it. And finally, on the bottom right, with respect to children, there needs to be, engagement between the players, the coaches, and the parents, so that safety is reinforced, particularly when children are growing and they may not understand fully the impact of what they do. To make sure that they learn that they have to stay within the rules of each game and play fairly and safely with other sports participants. Some of the advances in head injury assessment are biomarkers. So the research continues into determining some of the markers in blood samples that can indicate whether there's been injury to the brain. So that research continues. There's virtual reality and artificial intelligence tools which are now also being used. It looks like they will be able to possibly help in the gathering of information on a day-to-day, week-by-week basis, and then using different algorithms, assess whether an individual is getting better or worse following their initial concussion. I've just said about the ABC approach, resuscitation, advanced trauma life support approach to the emergency management. Always remember you approach an injured sports person, making sure that they're conscious, alert, the airway is clear, they're breathing, and before addressing the injury to the finger or the shoulder or the ankle. And just at the bottom there, sideline preparedness. So preparation and prevention of the team, the medical team, or the teams that attends any sporting event includes preseason, game day, and post-event planning. So preseason, certainly the referees, all international organizations for different sports have annual conferences, sometimes twice a year in different parts of the world, to make sure that all the referees will administer and enforce the rules and regulations are up to date with the latest guidance on different situations, looking more and more into prevention. So, players or participants are given warnings early to avoid things escalating. People who continue to disregard warnings are kicked off, given the red card. And these are all discussed. And on game day, both teams are reminded of the importance of fair and safe play. And then there are debriefs. There's debriefing after each game, and each doctor at the sideline or at an event and their team should be engaging in some sort of debrief to assess whether there were any incidents, if there were, how they were managed, and seek to improve the service they provide, and they're learning from each game and each season. This will probably, when I'll leave this for, but a couple of scenarios here. Got a football player that's an American football helmet-to-helmet collision with signs of disorientation and confusion. Now, I think Dr. Anand mentioned if as a team doctor, you get to know your players. So it could be simply asking a player a question that you know they should know the answer to because something happened on the team bus or the team plane, or within the last couple of days. So it's helpful if the sideline medical team is one that knows each other, stays and interacts and engages with the team. So that makes it easy to detect the subtle signs. Obviously, if there's significant disorientation and confusion, players have to come off, and then you follow the guidelines for that national or international guidance concussion. Usually, it's a minimum of a couple of weeks. At the professional level, they have access to serial, expensive imaging, and so on the basis of those, they may have 2, 3, 4 different imaging over a particular period of time, and a consensus opinion which may have to be agreed with the league. If there's an immediate unconscious situation or life-threatening situation, that's obvious. They get taken off, and then part of the pre-planning includes obviously making sure that you have suitably qualified medical staff, allied health professionals, standby ambulances, and just a reminder that where there are significant spectators, as in a stadium or a large indoor arena, there has to be planning for events or medical situations happening within the crowd. So if it means having a separate medical team just for crowd-related incidents, then that's what it's going to have to be. But obviously, the medical team directly on the sideline may not be able to be in 2 places. So for a big stadium, you may have to have 1, 2, or more, depending on the size of the crowd. Just almost rounding up here. In under-resourced environments, just a couple of things which I just thought, might be useful to consider. The pre-participation assessment, in all of it, even though there were some assessment tools, equipment, etc., which may be on the expensive side, I think it's clear that what we were taught in medical school still pertains even so many years or decades later. In other words, the basics of history taking an examination is key. And, still, even in spite of all the modern equipment, resources, 80, 90% of decision making can be done simply by taking a good history and clinical examination. Protective equipment will have to be dependent on resources. Enforcement of sports rules by officials does not need any huge, financial input. It just means that the officials have to be trained properly, know the rules and regulations, and enforce them, so that players do not get into situations where somebody breaking the rules causes a significant head injury to another player. Adherence to the general. So the general and sport-specific concussion guidance should be made aware that, again, this doesn't cost any additional money or finances. It just means all participants, players, their coaches, everybody needs to be aware of this guidance. I've mentioned about the sideline guiding. Now, networking at the end, which I've said is, it's important to plan ahead of time. So, network by making sure what the nearest referral center is to any sporting event or practice center, the nearest neurosurgery center, the nearest rehabilitation center or individual. Dr. Tano mentioned about the availability of specialized sports and rehab clinicians and consultants in Ghana. I mean, even if you are 2 hours away, wherever you are, it would be prudent to form a plan and then agree on what to do if anything happened beforehand, so that when it happens in 2 months' time or 6 months' time, you've got a plan which your team is comfortable with, and the receiving or the rehabilitation consultant is aware that you've thought about it, and they can give guidance. The key references. There will be other references dotted in the notes section of the PowerPoint that I send across. But there is a recent head injury assessment and early management guideline updated by the National Institute of Clinical Excellence in May of this year, and I strongly advise those who haven't seen it already to go through it. It's quite an extensive document, but there's a lot of evidence provided, and what it basically does is provide the latest guidance, particularly with respect to concussion guidance for members of the public and children, and it's basically summarizes a lot of the key points I've mentioned, but that is an up-to-date May 2023 document, which I would advise people to see. And almost finished now. You might ask, what's the point of being aware of a major incident triage tool? Well, if you're going to be playing in a football stadium or a basketball arena or ice hockey, any place where there's a crowd, 20 people, 50 people, 100, 200, 1,000, 10,000, there has to be planning, and people need to be aware. Somebody needs to keep calm and be aware that if part of the stadium collapses and there's 100 people there and 50 casualties, there is a system. So this is a simple triage tool that is just for information and awareness. So I share that also with you. That's also newly been updated and shared this year. So these two will go some ways, particularly for those of you who are involved in sideline medical management. That's just So in conclusion, head injuries in sports are common. Some sports are more prone to cause significant head injuries. It's important for everybody to be aware of the rules and regulations for safe and fair play. Important for enforcement of the rules, and then important for pre-planning and preparation by those who are going to be at events providing medical cover. That's in summaries my presentation on this. I hope you've enjoyed it. I'm happy to take any questions during the panel discussion. Thank you.
Thank you very much, Dr. Bako. The presentation was thoroughly enjoyed. We would go ahead and get a presentation from Novartis before we take our questions. So if there is any representative from Novartis, I'll be glad if you could start sharing your screen. And as you do that, please, I have some questions for our panelists. So I would like to share the questions as our resource persons get prepared. So Dr. Dalibo. So please, Novartis, our representative from Novartis, kindly go ahead and share your screen.
Hi, Doc. We are trying to share the screen. Please, can you see our screen?
No, please.
Okay. Let us attempt to share the. Okay. Sure.
Okay, yes, we can see your screen now, but if you could kindly put it on slideshow.
Okay. Is it on slideshow now?
Yes, please.
Okay. Okay. Then let's put on our camera and then we can hit.
It sounds as though you are far off from your microphone. If you could kindly get closer. Thank you.
Okay. That's okay. Is the sound better?
The sound is better. Unfortunately, we lost the screen.
Yeah,
but the sound is much
now.
better. Yes, we can't. Yes, okay.
Thank you. On too?
So good afternoon, everyone.
Good afternoon.
Thank you very much for the opportunity. My name is Carl from Novartis, and I'm here with my colleague Wisdom, and we'll be sharing some information with you on treatment options for pain management. So FlowTac, your partner for freedom. A partner could be an individual, an entity, or in this case, molecules acting together to achieve a common goal. FlowTac is a combination of two molecules, diclofenac and cholestyramine, that have come together to help your patients take back that freedom that has been stolen from them due to chronic and acute pain. Now, treatment strategies for pain. Typically, when you are considering an analgesic for the management of pain, you need to consider both the cause and intensity of the pain. So when a patient walks into your consulting room, you might want to ask the patient that on a scale of 1 to 10, how would they describe their pain? Because pain is very subjective, and pain is what the patient says the pain is. So on a scale of, let's say, 0 to 10 or 1 to 10, and the patient mentions a value of 5, then you should know that the pain is very excruciating for that patient. You need to go fast for the patient. You need to go hard. You need to give them the best and nothing but the best to manage their pain. Now, what are the characteristics of an ideal analgesic? What are the characteristics that an analgesic is supposed to possess to be able to give patients outstanding pain control? One, it should have a rapid onset of action and a very short half-life. Pain can be very excruciating for some patients, and hence they need a prompt response to their pain management. We need molecules that have non-opioid potency comparable to morphine without the risk of opioid dependence or respiratory depression. You also need molecules that do not have clinically significant side effects, because no matter how awesome a molecule is, if the patient does not find it tolerable, they cannot take it at the dose and frequency at which you have prescribed them. Now, the big question, are there unmet needs in pain management? Now, some patients have often complained that some of the medications they are on for the management of pain do not offer them adequate pain relief. Some patients have also complained of some level of stomach upset or irritation with some popular treatment options. At this point, scientists knew that there had to be some paradigm shifts from offering pain molecules that offer some level of pain relief and ask the important question, which molecule can I give to my patient to improve their quality of life? And ladies and gentlemen, I present to you that solution, FlowTac. Flotac is a diclofenac cholestyramine complex that offers patients pain relief within 20 minutes, as well as has a long-lasting effect of up to 12 hours. What that means is that if you give your patients one capsule in the morning and one capsule in the evening, you've effectively given them 24-hour pain control. Now, this was a study that was done comparing osteoarthritis pain on walking using the visual analog scale between Flotac and celecoxib. The study proved that pain on walking was typically improved in Flotac compared to celecoxib. The reason for this was the fact that even though celecoxib is COX-2 specific or selective, when we are talking about COX-2 potency, Flotac typically offers better COX-2 potency. Hence, its ability to both inhibit pain and inflammation is more pronounced. Now, Flotac is essentially a biphasic molecule. What that essentially means is that it offers your patients both rapid pain relief and prolonged pain relief. So what happens is that in the first 20 minutes of taking the molecule, about 70% of it is released into plasma. The remaining 30% is gradually released over an extended period of time, giving patients not only fast pain relief, but also sustained pain relief. So this is also another unique property of Flotac. When the molecule enters plasma, even when the concentration in plasma begins to reduce, there's an increase in the synovial fluid, giving patients localized pain relief and also improved mobility, especially with patients that may have joint-related pain. Now, this is how we depict the molecule Flotac. We depict the diclo molecule being encapsulated by cholestyramine. Now, a bit of history. Novartis is the innovator of diclofenac, meaning that we invented the molecule. Our first diclofenac molecule was diclofenac sodium under the brand name Voltaren. However, due to some of the incidences of GI ulceration with diclofenac sodium, it was important for us to come up with a new and improved formulation that offered better efficacy and safety, hence the birth of Flotac. Now, with the new formulation Flotac came new pharmacokinetic and pharmacodynamic properties. So comparing innovator Flotac to innovator diclofenac sodium using the Tmax, which is essentially the time it takes the drug to reach maximum concentration. Flotac offers patients pain relief within 1.25 hours, while sodium will do that in 4 hours, meaning that patients on Flotac have fast pain relief. When we look at the Cmax, which is the maximum concentration which the drug will peak in plasma, diclosodium has a Cmax of 0.4 milligrams per mole, while Flotac has 0.7, meaning that there's almost double the concentration available to penetrate effective compartments of the body, giving patients fantastic pain and inflammation control. Now, on the basis of safety, so this is the annual excess risk of each NSAID compared to placebo, popularly known as the Prague review. Now, when the coxib were first invented, the theory behind them was that if a molecule is going to selectively target COX-2, then it should offer a better safety profile. But a study that was done and sponsored by the British Heart Foundation proved that when we are looking at the safety of both celecoxib and Flotac, the safety profile was essentially comparable, meaning that on the basis of safety, there wouldn't really be a strong reason to choose one over the other. However, on the basis of efficacy, that Flotac was clearly superior. What that essentially means is that whenever you're doing an efficacy safety analysis, Flotac would always come up as your molecule of choice. However, another important thing to note is that since we're using equipotent doses, ibuprofen 800 milligram TID has the highest risk of NSAID-induced ulcerations at doses that offer comparable effects both Flotac and celecoxib. Now, Flotac is essentially a novel formulation from Novartis that offers improved efficacy and safety profile. So essentially, diclofenac sodium was the past. Flotac, which is diclofenac cholestyramine, is the future in pain management. Now, what we typically recommend when we are managing patients with pain is that you should always give the patients the lowest dose for the shortest period of time possible. So when the patient is in the acute phase, we encourage you to give 1 capsule 2 times daily for at least the first 2 weeks. When the pain is well managed, you can opt to give the patient 1 capsule daily to maintain for the patient. Now, Flotac can be used for varying indications ranging from acute chronic pain, from acute arthritis, chronic arthritis, alkalizing spondylitis, painful post-traumatic pain, and every other indication where the patient would require outstanding pain relief. We acknowledge that pain is one of the reasons most patients would opt to even come to the hospital in the first place, because the pain is affecting their quality of life. Now, imagine patients getting fantastic pain relief to some of these grueling conditions. Believe that if we're able to focus on giving patients better quality of life by opting for outstanding molecules like Flotac, would go a long way to improve patients' quality of life. And thank you very much.
Thank you too for your time. I believe there'll be questions for you as well. So kindly hold on, Novartis. So we'll go ahead with our questions to our panelists and then we'll ask Novartis. Maybe I should go ahead and ask. So averagely for people with chronic conditions like arthritis, how many weeks or maybe how many days, sorry, would you advise that the prescription is given for? And what's the average price for that duration?
Yeah, so typically, one of the things we always advocate for when managing pain is that no two patients are the same. So it will be based on the patient's presentation, the level of pain he's going through. But we always opt that whenever you're given for managing arthritis condition, you should give it to the patient to the point where you are confident that the pain has reached a point where it's no longer affecting the patient's quality of life. But for statistical purposes, we have studies that prove that patients have been on Flotac for up to a year without precipitating any severe GI ulceration. So we leave the duration strictly to the HCP's typical outlook on the nature of the patient's presenting pain.
Okay, and please, what about the price? The price of averagely for a week or so's treatment.
Yeah, so the typical pack of Flotac will typically cost your patient about 100 cedi for a capsule of 20.
Okay. So those will be my initial questions. Kindly hold on. I'm sure there will be other questions in the chat. So now some questions to our panelists. So to start with Dr. Dadibo, the first question is for me. I would like to know which position you played whilst you were in protocol, but that's an aside. The main other questions for you are, what are some of the practical strategies that a sports physician can offer patients to incorporate exercise and endurance training into the daily activities of someone who is undergoing rehab? So essentially the question is asking, what are some of the practical strategies that as primary care physicians or sports physicians would recommend that would incorporate in someone who is undergoing rehab in terms of their daily activity post the rehab period? The other question is, what are some of the potential risk or contraindications associated with exercise and endurance during the rehab process? What are some of the contraindications and risk associated with exercise and endurance during the rehab process? So I think those will be for you. Let me go ahead and ask Dr. Anand so that so for Dr. Anand, the question came to, what is your opinion about the role of regenerative medicine or PRP in post-injury cases? The role of regenerative medicine or PRP in post-injury cases. The second was, what is the outcome of neglected meniscus repair? Is it recommended? Is it recommended to be done as opposed to conservative therapy? So that's the second question. The third question for you, Dr. Anand, was, could you kindly comment on reducing dislocation before imaging as opposed to the vice versa? And the considerations are, how would you exclude, for instance, hairline fractures or other bone fragments? So those were the three for Dr. Annan. Dr. Bakal, there was a question in the chat box. Kindly bear with me. So as a team doctor, Dr. Bakal, the question is, as a team doctor, how do you also stay safe and care and okay, so as a team doctor, how do you also stay safe? And who cares for you, for instance, if you get hit by a baseball or by a small ball mid-air? The other two questions for you, Dr. Bakal, are there specific age-related considerations during the management of head injuries? Are there specific age-related considerations in the management of head injuries? And the last for Dr. Bakal is, are there specific signs or symptoms that indicate more severe head injury in cases such as concussion? And how can these be identified and evaluated on the pitch side? These are the questions that have been shared so far. So, Dr. Dadibo, please don't forget my question about the role you played, the position
The role
you played.
I played, I was an attacking midfielder. So, right. So, very interesting questions. I think the question about the risks with regards to rehabilitative exercises. So basically, the risk is that you can re-injure yourself if you don't if you are not careful with the kind of exercises. Now that's why we talked about the timing, we talked about the team that is involved to explain the principles. We emphasize the fact that pain is the key indicator as to when to stop. So we go through exercise, you start slowly, small intensity, and then you build up. And that is how you maximize the recovery. Now, basically, exercise increases blood flow to any injury site. So without adding the exercise, thinking that, oh, if I do the exercise, it might get worse, that rather causes the player or the athlete to have a late rather recovery, and in fact might not be able to achieve the level of performance he had. So that's why the rehabilitation medicine is very, very important for athletes and players to understand the principles, apply them appropriately so that they can recover quickly. There was a question also about I've even forgotten what the question was, but
sorry. So the next question was the practical strategies that you would recommend that are incorporated in a patient, the patient's daily life post rehab period.
Exactly. So the practical strategies is also to follow the same principle, the flexibility exercises, the strength exercises. You know, when you use these techniques, you actually prevent further injuries. So when you follow the advice that is given, that you have a trainer, a physical trainer who takes care of or supervises the exercises, and then you stick to the advice given by your doctor, then you are likely to go through the process and recover very well. But if you don't follow those advice, then in fact that would will jeopardize your recovery. And I think it's all about teamwork, understanding all the parts. Your manager, your coach, everybody should be involved. Sometimes the managers have, because they work with the players more closely, they have a good rapport with them, and they are able to explain things better to them, and hence help with the rehabilitation process. Unfortunately, sometimes the converse happens when, because of the pressure to come back to sport, there is always the tendency to overdo things. And that is why I show the video about the practical ways of managing these things. So some of these videos are available. You can watch it and follow the same things, and then you can have a better recovery. I hope I have answered the question.
Yes, please, except my first question.
I said I was an attacking midfielder.
Okay, thank you very much. Dr. Annan, please. It's your turn now. I think you are muted.
Okay, I've got it. Yeah. I think the first question was regenerative medicine, isn't it? Which
Yes, please.
It's a new innovative kind of treatment which is coming up. I mean, it helps in healing. Techniques vary, but one of the problems we have is the efficacy of it. I think on top of my mind, I think the efficacy is possibly around 80%. So it's quite useful if you have the technique and resources to use for regenerative medicine. I mean, use across MSK, in osteoarthritis, even in heart diseases is used for. It depends on where your specialization is, how you've been trained in it. Training is not very well structured or standardized, and policy and manufacturing is a problem as well. So most of these clinicians who specialize in regenerative medicine are in private care, private healthcare. So if you have the technique and if you've been trained for it, that is useful. I'll recommend it if you are trained in it. It's quite useful. Now, how do you use it in team sports? It will be, it depends on your rapport with the players. I mean, Dr. Dadibo has played football at the highest level. He will tell you that when he gets injuries, he wants to recover very quickly. It's one of those things and that will not fit that bill. I mean, you can't introduce this regenerative medicine in that area. But if you have the skill, you can use in a private practice, and you need to let the player understand how it's done, and they have to be patient in terms of its use. But it's quite useful, and I'll say it again. I think it's about 80%. I've seen 90% before in terms of this treatment, but you have to choose your patient very carefully if you have the technique and ability to use resources to do this. I hope I've answered the question, actually.
Yes, please.
The next one, I think, is neglected meniscal injuries. I mean, the question was, I'm not sure whether it's...
The question was asking the outcome of neglected meniscal repair.
Right.
And is it recommended as opposed to general conservative management post-injury?
Yeah, well, I don't let that happen in my view so far. I mean, once you get the diagnosis right and clinically and use an MRI, in team sports, you have to get them to be seen by the orthopedic surgeon. That is standard. You lose that, then you have that risk of meniscal injury. If that happens in team sports, you are on your pathway to be sued in court. It just doesn't happen. I mean, you just, once you get it clinically or on MRI, that's the next call of action. You will have to refer for surgical intervention. So that is my take on it.
Yes, the last question had to do with reducing dislocation before imaging and the risk such as excluding hairline fractures and bone fragments, maybe on the pitch side, vis-a-vis doing it post-imaging.
Yeah, I mean, I've seen both sides before in team sports. I mean, but my take on it is this. I'm looking at the player. I don't want the player to go through a lot of issues from the pitch to return to sports. Now, this is what we need to bear in mind. Now, you are at a vital position to reduce this dislocation. When the muscles are not so tight, you're not contracted, which will make it difficult to do. That's the best gap to use to reduce it. And you are less likely to damage the glenoid or cause a defect on the head of the humerus. So it's best to do it. You do it that way, it's much easier. Now, if you leave it and get the ambulance to take to the hospital. You go to A&E, there's a bit of a wait. You have to wait there, takes a while. A lot of these clinicians who are there, the doctors, some are junior, they will not understand this well. They would send you for x-ray, which again delays. So you get the x-ray, you come back, you wait for somebody else to assess the x-ray, decide, oh, this is anterior dislocation, so let's reduce it. There's a lot of time that's lapsed. So then the risk is it becomes more difficult to reduce. Now, if you are reducing these ones where it becomes difficult, I've been involved in a few before, the risk of you forcing it, because the muscles, now you're fighting against the muscles, of this chipping the glenoid, causing heel sacs or damaging the articular cartilage of the head or the femur, causing things like Bankers, and so then it becomes more difficult. I've seen a scenario where a patient like that has had to be reduced in theater under general anesthetic, and post X-ray and MRI has shown these lesions. So now the player then has to go through processes of surgery again. I think that's unfair on the player and his career. So personally, it depends on the literature you read. Personally, it's best to reduce then, unless you don't have a technique to do that, which is fair enough, then you can do that. But as you do that, you have to explain that to the player so that the player understands what the process is. Because I'm very wary of a player coming back to take you to court, because that has affected his shoulder sometime in the future. So then they come back to you to say, well, this is why this happened. So there's pros and cons on either side, but I will be more prone to reducing it on the pitch if you've got a skill.
Thank you very much, Dr. Anand. So, Dr. Bako, I think the last set of questions were.
Yes. Hello. Yeah. Can you see me all right?
Sorry, we can't hear you from here.
Can you hear me all right now?
Yes, it's much better now.
Yeah. Okay. Right. So I think I had a question about what happens if the doctor leading the medical team at the pitch is injured. So I think you may remember I mentioned about the team, which is the event site, the medical team. There should be a pre-season planning, pre-game planning, post-game debriefing, or learning. So what this means is that there's a concept of, as part of team building, team learning, of what do you call it? Tabletop exercises or simulation. So if you are one or two or more doctors, you can draw up a backup plan as to what happens in that eventuality. If you are a sole clinical lead, then remember I mentioned about some of the basic resuscitation courses, such as the advanced life support for medical emergencies and the advanced trauma life support for trauma. So if you have a well-trained team, each member of that team should know what to do, the basics. So they should be able to assess the doctor, make sure their airway is clear, their breathing, including making sure they are stable, and get them into the ambulance to the hospital. So it basically, in summary, it involves pre-planning and making sure that you, as the lead for the team, you have effectively a deputy, even if that deputy is not a medical doctor. They should be able to cater for that eventuality when you get hit with a golf ball or a baseball or a football.
Great, thank you.
Yeah. Then the second one was about
had to do with
age-related consideration.
Sorry.
Yeah, the second one was as to whether there were any age-related considerations with head injury. So yes, there are, and usually age-related issues have to do with the extremes of age. So very young children or the elderly. Now, with very young children, the history part can be challenging, because if the child is a toddler or not speaking properly yet, you're not going to be able to get much out of them. So you have to depend solely on clinical assessment. If it's an elderly patient, there may be confusion because in an elderly patient who has an element of mild dementia, you don't know whether the head injury is causing the confusion or whether it is just normal for them and they actually haven't been affected by the injury at all. Also, people of an older age are often, some of them are on anticoagulants. So they may be on anticoagulant warfarin or other anticoagulant treatment. And so that immediately puts them at a high risk and they may need to be observed at a minimum. The last one was signs and symptoms suggestively unconscious. Um, you know, it's straightforward. If they have a seizure or they cannot move an arm or a leg, those are all straight away. The concerning things are if somebody has a significant adverse or abnormal item in their history. So if they've had recurrent concussions or they had one recently and they've just returned back, and with something like epidural hematomas, if you have a situation where somebody has a very brief loss of consciousness, they appear to be well, and then suddenly start feeling unwell, there may be an epidural hematoma which may be expanding and need emergency evacuation. So, I mean, those are my initial responses to that question. But yeah, the subtle ones in medicine, it's often the ones that are not clear that you have to worry about.
Thank you very much, Dr. Bako, and thank you, Dr. Anna and Dr. Dadibo, for your presentations, and for our participants on YouTube. We are grateful for your time, participants on Zoom as well, and for our in-person technical team that helped us, IT. We are very grateful for your participation. We'd like to say for those who registered for the CPD, there would be a soft copy of the certificate that will be sent to your emails. And also, once you register for the CPD, CPD points would be assigned to you eventually. At this point, I would like to call Dr. Maxwell Amu to give us a closing prayer as we start with an opening prayer. Once again, we are grateful for your time.
Okay, shall we pray? Prophet man.
Before we take the closing prayer, I would like to call Prof. Isuman once more, if there's closing remark with regards to all the time and the knowledge you've acquired during this period for the update. Prof, please, we can't hear you. Prof, we can't hear. Sorry, I think we have a challenge with Prof's connection. I'd like to acknowledge Novartis and Hills Pharmacy for being part of this presentation. Whilst Prof reconnects, Max, Dr. Matthew Olamo, can you give us a closing prayer? Hopefully, Prof will connect after you are done. Thank you.
Okay, shall we pray, please? Our Heavenly Father, we are so grateful for today and for the successful and fruitful discussion we've had. We are so grateful that we are going to continue to make family medicine an influence and a force in our healthcare in this nation. We are also grateful for the facilitators and the speakers you gave us today. We thank you for their time and the knowledge shared. We ask, oh Lord, that you continue to expand them and increase them in their field of expertise. We are grateful for all the participants who took part of this meeting. We ask, oh Lord, for the enablement to be able to apply this knowledge and the wisdom to attach to this information that we have had, so that our patients will be of good benefits or benefits maximally from this information. And then we ask, oh Lord, that you continue to make this day a fruitful and a peaceful one, even as we journey back to our various destinations. We thank you so much for a fruitful discussion. In Jesus' name we pray thanksgiving. Amen.
Amen. Hello, Prof, please, can you hear us? Hello, Prof. Sorry for the technical hitch. We can't hear Prof, so at this point, we'd like to.
Okay, it sent a message.
Okay, so Prof has sent a message. So from Professor Suman, says, I'm sincerely grateful to all our facilitators. Thank you very much. We'd like to bring this meeting finally to an end. Thank you very much and hope to meet you at either another CPD from the faculty or an update. Have a good evening. Bye.
Bye.